Sir, myself, Dr. Kulkarni and Dr. Sadat Qureshi, we are chairing your session here. It's very pleasurable for us to listen to you and then and
Thank you,
great
sir.
teachers like Dr.
Pleasure
Satish.
is all mine to be part of this conference, this prestigious conference, and I'm truly indebted to the organizing team for giving me this opportunity to be with you,
Sir,
especially Dr. Yashveer and his entire organizing committee. Once again, thank you so much for involving me in this prestigious conference and
sir,
giving me this opportunity to carry this live surgical session.
thank you, sir. Thank you, sir.
Thank you. And I know it's early morning, the winter starting. So let me know when to start when people come so that we can go ahead.
Sir, I think we can start off because we have got a quite good crowd here now and they are waiting for your master surgery to get.
Thank you.
started.
So today's session involves basically focused on endoscopic surgery. Even I got calls from a couple of junior colleagues to initiate more and more discussion on endoscopic sinus surgery and advances, which is a hot topic for all everybody. Otology, we all know, is a established science in all medical colleges and everywhere, and sinus surgery is evolving more faster now. So we'll focus on endoscopy today with variety of cases starting from basic to advanced. We'll focus on anatomical part, on radiological part, and intraoperative nuances and decision making. And I'll request audience to participate with more and more queries, questions, suggestions to make it more interactive.
Okay,
So
sir.
our first case is a young patient, male patient, having complaints classical of CRS. CRS, we all know, is a clinical diagnosis. There are certain criteria to label diagnosis of CRS. And there are certain predominant symptoms like nasal obstruction, rhinorrhea, sometime headache, facial pain, loss of smell, whatever. So there are certain predominant symptoms which, along with the endoscopic findings, nasal endoscopy and radiology, you can establish the diagnosis of CRS. And CRS, why I put this session on CRS? CRS is not a simple disease. It's like a syndrome. Every case of CRS is different. The pathophysiology of CRS is better understood now. It looks like chronic rhinosinusitis is an infective disease. There's a myth. This is not at all infective disease. The predominant pathophysiology is inflammatory disease. Yes, secondary infection may prevail, which invite treatment of the infection as well. But the predominant pathology is inflammatory and it is related to the nasal immunity. And every CRS is a different case. There are variety of endotypes of CRS have been described now. We'll discuss today. And every endotype has a different pathophysiology, different, treatment protocol, different prognosis. Everything is different. You can't treat every CRS on the same lines. This is what we need to know with time. So this particular case, we are starting with the basics, which we see in our clinical practice very often, a patient with nasal polyposis. And we all know this is an inflammatory disease. Medical treatment is the core treatment. For any CRS, any sinusitis, medical treatment is the core treatment, with surgery reserved for certain situations and to facilitate medical treatment. Now the role of surgery has been redefined. It's not that you operate upon a patient with polyps, CRS, and you get away and the patient is cured. So we have to understand the role of surgery in when surgery is required, the role of surgery, what we are gaining out of surgery, and how we facilitate medical treatment to optimize the treatment. And this is important part of the counseling as well. Many a time patient come to us that I got operated and I got the polyps again. That information to the patient is because of lack of adequate counseling. So this is an inflammatory disease, particularly polypoidal disease is eosinophilic driven, and the core treatment is steroid. So the moment you give steroid, the moment you start oral steroid, patient will improve. But we will know in our hearts and hearts how long you can give steroids. So the polypoidal disease, which is more common, more difficult to treat kind of disease, this first case is a polypoidal sinusitis. The role of steroid is the core treatment, but we know we can't give for long because of their own adverse effects. So in order to facilitate steroid treatment, surgery has a big role. So role of surgery is very well defined. We have to counsel patient. The role of surgery is to facilitate medical treatment so that we can give way for the topical steroids to penetrate to the nasal mucosa or sinus mucosa. Why I'm saying this? Because this pathophysiology of this polypoidal disease is pretty well understood now. And every cascade of pathophysiological, path, the steroid is the core treatment. It is driven by certain cytokines, and at every level, the steroid is the drug which works. So, in order to facilitate the medical treatment, the topical steroids, we need to do something to, make sure that the steroid penetrates topically to the depth of the sinus mucosa. And there comes the role of surgery. And when it comes the role of surgery, then we should know the three-dimensional anatomy of the area where we are going to operate. And this is where the role of CT scan comes. Because these sinuses are so strategically situated between the orbits and the skull base. See this? From anterior, posteriorly, from everywhere, all these sinuses are in close proximity to the orbit on either side. And similarly, you see this, all these sinuses are in close proximity to the skull base. So the margin of safety in this sinus surgery is very low. Even a sub-millimetric deviation or sub-millimetric disorientation can lead to fatal complications because all these important structures are in close proximity: orbit, skull base, carotid artery, optic nerve. They are in close proximity, and the anatomical variations are pretty common in paranasal sinuses. So you have to be well versed with the three-dimensional anatomy of the given area, that is paranasal sinuses and surroundings. And in surgery, you have to utilize this three-dimensional anatomy to conquer surgery with safety. This is very, very important, and the safety quotient in this surgery is low. So you have to be very well, familiar with the CT scan, understanding of the CT scan yourself. You know why I'm saying this fact? Because the radiologist, what do radiologists report in this particular scenario? Like in this particular case, radiologists will report in one line, the patient is having bilateral pansinusitis. We all know that. This doesn't carry any additional significance to us as far as the surgery is concerned. What we all know from the radiology is the anatomical details, which radiologists do not provide. Even we have tried, to give a radiologist pro forma of each and every detail we want, like the kind of cellularity, whether there is frontal cell, whether there is agarnage, this cell, that cell, onodi, the distances, configuration of cribriform, septal deviation, height deviation, so many 300 points, and radiologists can't give that much of time to fill that pro forma to give us every detail. And even if they give, it is of hardly any value unless you, relate yourself with a three-dimensional anatomy. So the onus is on the surgeon to order adequate radiology and develop understanding of reading the radiology himself or herself. That is the need of the time. This is what we always, propagate. So quickly in this case, what radiological, important parameters which can affect this case, what all need to be taken care of, and how they are important. and how you can relate intraoperatively. Every single radiological finding has to be related intraoperatively, and that can dictate your surgical approach as well. We have, as I told, the variety of endoscopic cases lined up today. This is the most basic case for the junior colleagues to become familiar with the endoscopic anatomy. Then we'll move on to the more difficult draft and draft 2, draft 3 cases. So this is all part of endoscopic sinus surgery. And since this endoscopic surgery is evolving with time, with a greater pace, we have to understand the surgical nuances well and decision making. So in this particular case, first of all, as I mentioned, what kind of radiology we should order? This, see, again, the onus is on the surgeon. So one should order sub-millimetric section, 0.5 mm, 0.7 mm, whatever, according to the machine you have. Sub-millimetric axial section of paranasal sinuses, non-contrast, that's it. And this software will, reconstruct into various planes. So this is axial section. This is what to be shot on CT scan machine, that's it. Then this DICOM software will reconstruct three-dimensionally into various planes. So for example, coronal plane. See now the section size on the lower left side, 0.4 mm sections. That means with every move, I am going to move with 0.4 mm so that I don't miss any important structure in between. This is very important to have the value of fine section radiology. Secondly, you can relate every structure three-dimensionally. In medical colleges, teaching institutions, this is a great software to teach students. Every anatomy we must know to relate in all planes. For example, if I'm looking at the intersinus septal cell, I should be able to relate in all three planes where the intersinus septal cell is. What is the value of planes? Certain anatomy is better demonstrated, or the best information is displayed by certain sections. Like for example, coronal gives information of majority of the sinuses in detail, and that gives you, we are so familiar with the coronal because it gives you the information in the same plane in which we operate. Similarly, certain information is given best by the sagittal planes. Like for example, see in the sagittal planes, the frontal sinus anatomy, frontal beak, frontal recess, the skull base anatomy, these are best given up by sagittal planes, and we must have sagittal plane if we really want to do a good frontal sinus work. Similarly, the axial sections give details in certain planes. Axial section give information, certain information better than coronal and sagittal. Like frontal recess anatomy, intersinus septal cell drainage anatomy, Onodi cell anatomy, all these are better given up by the axial cell. Septal deviation all the way, nasolacrimal anatomy, all these are given by the axial section better. So we must have three-dimensional plane CT scan, and the onus again comes to the surgeon. Secondly, we must have this anatomical details in the dynamic fashion so that we can relate this each and every anatomy in all planes dynamically. Intraoperatively also you can take the reference. See this. This is my frontal bone. This is pneumatized frontal sinuses. Look at the frontal sinuses on both sides. Coronal plane. Look at the frontal sinuses. This is the frontal beak. Frontal beak is where it makes the floor of the frontal sinus. Look in the sagittal. See, this is the frontal beak. This is the frontal beak in sagittal, and this forms the floor of the frontal sinus. So as long as the frontal beak is intact, what you see above is the frontal sinus. This is so important in anatomy that you need to relate intraoperatively as well. Why? In endoscopic surgery, like we do sinus surgery, see this. This is the frontal beak. When we come with the endoscope from here to reach out the frontal sinus depth, this beak is the biggest obstacle. This beak is the biggest obstacle, and this is the thickest bone in the region. And when we come with our endoscope, it is difficult to reach out the frontal area, which is so strategically anterosuperiorly located. And this beak is the obstacle. Like, for example, if we come with the endoscope like this, cannot watch out for the frontal sinus, and then you need angled endoscope from here like 70° or so, or 90° or so that we can watch inside the frontal sinus. So the obstacle is the beak, and today we have couple of cases how this beak, affected the overall outcome and the frontal sinus drainage system. And you need to revise those cases by drilling of this beak, which DRAF has innovated as a variety of draft procedure. And this is very, very important part of the sinus surgery armamentarium. So one must be well versed with the, drilling or dealing with the beak in order to optimize the frontal sinus results. So today our focus will be more and more on the frontal sinus, because wherever I go, I often question more and more on the frontal sinus, difficulty in frontal sinus and all those things, and we'll discuss in detail today. And drilling the beak is the key in, simplifying the frontal sinus surgery. So this is best understood on, this thing, the CT scan. So dynamicity of the CT scan is very important. Why it is important? Why onus is on the surgeon? Many times the patient comes to us with a CT scan plate in hand, a single CT scan plate in hand. The reason being, the previous surgeon had ordered the CT scan PNS. That's it. And what will radiologist do? That will furnish the CT scan in less than 10 seconds by giving 5 mm section, 10 or 20 slices. That's it. Without even focusing on the fine section, without even focusing on the axial coronal sagittal plane, and that to a plate which is not a dynamic CT scan, and it is of hardly any value as far as the sinus surgery planning is. And in that situation, we have to order, unfortunately, other CT scan. Sometimes patient doesn't want that I am already having a CT scan while you are necessarily getting another CT scan done. So you have to understand, all colleagues have to understand that whenever we order a radiology, we should order adequate radiology to get adequate information to make our surgical life much, much easier. We can take the advantage of this radiology. Radiology is a science which is growing much faster than the surgical science, and we can always take advantage of it. So this kind of a radiological detail we want in these patients. Come on. So what kind of CT scan to be ordered? Axial section, reconstruct into all planes, and then relate every structure intraoperatively. See now, in this particular case, why it is important. See this frontal bone pneumatized and two unequal pneumatized frontal sinuses. Can you see? Am I audible, sir?
Yes, sir, audible.
Now, this is the beak. As long as beak is there, what you are seeing above are true frontal sinuses. Now I am going behind and see another pneumatization appears. This is the first pneumatization, most anterior pneumatization as far as cellularity is concerned. The first cell to appear, not sinuses, are the intersinus septal cells. And see, this is intersinus septal cell, which is at the expense of pneumatization of the intersinus septum. Now, see this earlier two sinuses now look like three frontal sinuses, but there cannot be three frontal sinuses. This is intersinus septal cell. And once this cell you detect, it is, the onus is on us to give ventilation and drainage to this cell properly. How you can give? By understanding the drainage pathway. Follow this CT behind and see where this cell is draining. This cell is draining in the right part of the nasal cavity. Can you see this? Right part of the frontal drainage pathway, right side, not on the left side. So this frontal intersinus septal cell is communicated to either of the frontal sinus drainage pathway, and this is very well seen on a dynamic CT scan that which side it is communicating. This is on the right side. And while performing the right side frontal recess, drainage pathway, what you need to do is remove this septum to make a common drainage pathway with the frontal recess drainage pathway of the right side along with this intersinus septal cell. I hope it is very clear.
Very clear, sir.
So this, how you can decide this kind of a treatment on the basis of a dynamic radiology. This is so extremely important. And without focusing on the radiology, what ultimately you do, you end up doing incomplete job, incomplete drainage pathway system because of incomplete information from the radiology, and ultimately patient suffers and this surgery gets a bad name. So in order to execute, as far as the surgical results are concerned, because surgery is a part of treatment, not everything in sinus surgery. It's the beginning of treatment of sinus surgery, sinus disease, I would say. But once it comes to surgery, it has to be properly executed. Improperly executed surgery has its own adverse effect, complications, and persistent disease and ineffective medical treatment later on. So this radiology is very important in executing a proper disease, surgical path. Now, this is the beak. As long as the beak is intact, you are still in the frontal sinuses, and this is the big intersinus frontal cell. If you treat the frontal sinus on either side and do not remove this intersinus, the septum between the right side frontal sinus and the intersinus septal cell, the pathology will continue. Symptomatology may continue, and then you ultimately, come back again, need to come back again to treat this. Now see, I am going behind and the beak is going off. Now the beak is going off. Until then, this beak is there. So what I am trying to say, this beak forms the floor of the frontal sinus. This is the most important anatomy we are going to relate intraoperatively as well. As long as beak is there, you are in the floor of the frontal sinus. Frontal sinuses drain from behind. See this. See in the sagittal plane. Frontal sinuses drain from behind. See this. This is nasal bone. This is the beak. This is the beak. This is the beak. This is the beak. And this is the frontal sinus, and frontal sinus drains from behind where the beak ends. And this is what we need to extrapolate in surgery as well. What we'll do with our 70 degree, we will follow the beak, follow the beak, follow the beak. Where the beak ends is the entry into the frontal sinus per se. Until then, you are in the frontal outflow tract, frontal recess, not in the true frontal sinus. So the best anatomical landmark which God has given us, a very stable, robust landmark, is the beak for the frontal sinus. And this is what I'm going to relate intraoperatively as well to simplify the frontal sinus, surgical exercise for junior colleagues or anybody who's stuck in the frontal sinus surgery. Forget all landmarks and follow the beak. Anterior to posterior, here no other important structure is there in the vicinity. Only this thick bone, and where this thick bone ends is the frontal sinus. Same thing on the opposite side. Follow the beak, where the beak ends is the frontal sinus. So simplest way, even in the revision surgeries, until the draft is, done, this beak always remains intact. In the most revision procedure, most difficult situation, whatsoever the anatomical or the cellularity or whatsoever abnormality is there, the beak always serves as a great landmark. This doesn't change. Follow the beak and then enter into the frontal sinus. So this is one of the most important anatomical landmark for the frontal sinus. Now where the beak ends, now coming back in the coronal section, where the beak ends, now this is the frontal drainage pathway. See on the left side, this is frontal sinus drainage pathway, and this is the right side frontal sinus drainage pathway, and this is the septa which is separating this intersinus septal cell, and once we remove the septa, then it becomes a wide drainage pathway. This drainage pathway, widening the drainage pathway, is the key in frontal sinus surgery for two reasons. One is to establish the ventilation drainage, which is important for the good health of the paranasal sinuses. Another, this wide opening serves a pathway for the topical to go in the depth of the paranasal sinus. We all know it is steroid dependent disease most often, and the core part of the surgery is to give access to the topical steroids to the depth of the paranasal sinus mucosa, which is actually disease part. So in order for the steroid to reach there, we need to make wide openings, and this is how this removal of the septation makes your life, easier and make the surgery successful. So this is important to understand on radiology. Now, another thing, as we go behind, now see, as we come behind, there are lots of other structure coming in the picture. See this. This is the cribriform plate. So cribriform plate is a structure almost a centimeter behind the beak. This is important. See, I am going anteriorly. This was the frontal sinus. This is the beak. When the beak disappears, see this, the cribriform comes after a centimeter. This is so important as a safety caution. This is for junior colleagues who are always afraid of breaching the cribriform plate and giving a CSF leak. And see, if you don't know, if you are not aware of this, understanding this relationship, whenever you are working in relation to the frontal sinus, you are always scared and end up doing a clinical job, see this, let me relate in the three-dimensional plate what I'm saying. Otherwise, surgeons end up doing incomplete job. See this. This is the beak which has gone, and now the cribriform has come. If I take my cursor on the cribriform here, now relate in the sagittal plane where the cribriform plate is. This is the beak here. This is the beak here. The beak is here. The posterior most part of the beak is here, and the cribriform is there. See this. If I relate a line, if I draw a line from here to here, this is more than a centimeter always. From the posterior most part of the frontal sinus to the beak. Posterior most part of the frontal sinus beak to the cribriform plate is more than a centimeter. Why I'm saying again and again, the cribriform plate is more than a centimeter behind the frontal sinus work. So when you are working in the frontal sinus region, shatter your fear. Because of this fear, the surgeon end up doing incomplete job in the frontal sinus for the fear of injuring the cribriform plate. So this radiology is so important to guide you that your cribriform plate is more than centimeter away. This I will show intraoperatively as well while doing this work at the frontal recess area, that you don't have to frighten yourself with the cribriform plate. Cribriform plate is a centimeter behind the beak. Always focus on the beak. I will show intraoperatively where the beak is and where the cribriform plate is, and how you can work, in a satisfactory way, doing a complete job in that region without having a fear of cribriform plate in mind. So this is so important. So behind the frontal sinus, now the frontal sinus is nowhere in the picture. Again, see, the frontal sinus is anteriorly. This is coronal section. As long as the frontal sinus is there, no maxillary sinus in picture. You can see. Now I am going behind. See, this beak has gone. And what is this? The maxillary sinus has started appearing. When beak has gone, you are so behind the frontal sinus. Whatever picture you see below, there's the maxillary sinus coming in picture. There cannot be frontal sinus above. If you sometimes see pneumatization, more and more pneumatization like frontal sinus, with the maxillary sinus below in picture, that cannot be frontal sinus. This is supraorbital recess. This is such a posterior structure. What I am trying to say, this anatomy is complicated by certain variety of cells here in the frontal recess region. and how you can pick up with the, radiology. This is anterior, where the frontal sinus. So anterior frontal sinus is, and the maxillary sinus is behind, which is not in picture. Now you have come behind and see the picture of the maxillary sinus. Now, once you see the maxillary sinus, you cannot see the frontal sinus. What you see is the supraorbital recess, which is behind the frontal sinus and going and pneumatizing above the orbit. This orbital plate, this is pneumatizing the orbital plate of the frontal bone. This is supraorbital recess. So this is a structure behind the frontal sinus. Let me relate again on 3 dimensions. See this frontal sinus going behind, and this is supraorbital recess. Now see where the supraorbital recess is. See the frontal sinuses you have left anteriorly, and this structure is far behind. This is supraorbital recess, and this is above the orbit. So we need to differentiate all this anatomy. This is very important. Today we have a case where we are going to do orbital transposition for the pathology which is demanding. And in that situation, this medial wall of the orbit has to go completely. If this medial wall of the orbit in a huge supraorbital recess, if this superior-medial wall of the orbit, this bone is removed, you can have a wide access into the supraorbital cell far laterally. Now, there is no limit, which is, or I would say nothing limits the lateral, work in the paranasal sinuses. Earlier, what we used to believe with the instrumentation, any disease which is going beyond the mid-orbital plane laterally cannot be addressed endoscopically. Now, with certain advances in the surgical science, even the disease which is going right up to the pterion, one can address by certain modifications and orbital transposition. Endoscopic orbital transposition is one of the way. And today we have a case to demonstrate you how orbital transposition can, make your lateral access so easier. This is important. So coming to the radiological part again, this is cribriform plate as you go behind. And from the cribriform has 2 parts. Say this cribriform plate has 2 parts. This is the medial lamella and this is the lateral lamella. See this thin medial lamella, thin lateral lamella, and this lateral lamella continues with the frontal bone laterally. This lateral lamella of the cribriform, this lateral lamella is in close proximity to the ethmoidal cavity. And this is where this is most often at risk. While working in this frontal recess region, if you are too medial, one can easily damage this lateral lamella and get a CSF leak. The commonest site of intraoperative CSF leak as a complication is this region. So, while working in this frontal recess region, one should direct all your instruments laterally to prevent this damage to this fragile lateral lamella of the cribriform plate. So, this cribriform plate, you must focus the configuration more deeper the olfactory fossa. This is olfactory fossa. More deeper it is, more deeper lateral lamella, more longer lateral lamella, more longer area in relationship to the instrumentation, and more are the chances of injury. So we have to see in the pre-operative CT scan how risky the lateral lamella is. Then see at the junction of medial and lateral lamella, there are 2 structures, bony structures going down. These are middle turbinates. These are very important structures. See, this is the first part of the middle turbinate lying in the vertical plane or the sagittal plane. Then this turbinate, if I follow the turbinate, see this turbinate goes behind. I will show you intraoperatively. This turbinate turns laterally to insert on the lamina papyracea to make it basal lamella or ground lamella, which differentiate the anterior from the posterior group of cells, and then the third part in the axial plane. So this is the turbinate. Why I am showing here? This first part of the turbinate, particularly high up, insert on the very fragile cribriform plate. Dealing with the lower part of the turbinate may not be risky, but dealing with the upper part of the turbinate, you have to exercise highest level of diligence and caution so as not to manipulate too much turbinate at this level. If you manipulate too much the turbinate here, you can give a distant fracture and a CSF leak, which, because this turbinate insert on a very, very fragile cribiform plate at the junction of lateral and medial lamella. So we have to be very, very cautious at this level that the turbinate should not be handled, so extensively. So as we go behind, we have seen maxillary sinuses, a lot of polyps in the cavity, like a common cavity kind of a picture. Because of the disease, all anatomy is disturbed. Then you go behind, this cribiform plate is over. Then these two turbinates attached on this flat roof, this is posterior roof. These are superior turbinate, bigger posterior cavities. Then as you go behind is the sphenoid sinus. This is intersphenoid septum and the sphenoid sinus. So we have to be, very, very familiar about understanding this anatomy of the paranasal sinuses radiologically, so that we can utilize this information to improve our surgical exercise, to do a comprehensive work, yet with complete safety. This is what the goal of the sinus surgery is. Any questions at this point of time before we move on to the surgery? Any questions? This anterior ethmoidal artery I forgot to mention. See, this is the orbit, this is the medial rectus muscle, this is the superior oblique. At the confluence, this beaking of the orbit leads to a canal which traverses through the lateral lamella. See here as well, this traverses through the lateral lamella of the cribiform in the olfactory fossa. Intracranial, then it comes down, back in the nasal cavity. So this is for the anterior ethmoidal artery. It is more prominent, more without bony covering, when the skull base is over pneumatized in this region, because this passes through the thickness of the ethmoidal roof. If the thickness is less because of over pneumatization, the artery becomes more prominent and more at risk. So this you can gauge from the CT scan as well. This is not very prominent in this case, as the skull base is not over pneumatized here. So this is not at risk much, but you have to respect the anatomy and save this vessel. Unnecessarily injuring to this vessel has its own consequences. So any questions, sir? Anything more you want me to show? Because this is CT scan is endless to discuss, but we must know the important clinical points in this particular case to relate intraoperatively.
This case, we had a very extensive polyposis, sir. And
Yes.
a lot of the bony structures, a little bit seems to be eroded. So eroded in the sense thinned out. So what is
Pardon,
the,
sir?
I mean, thinned out. Many of the structures, bony structures were thinned out.
Yes.
This one. So
Yeah.
what is the ideal window width and then window level at which we should actually see these CT scans?
See, the CT scan is short. See this on the left side, the variety of CT scan pictures here. So when you order CT scan, we must order in bone and soft tissue windows. See this. This is bone window. Bone window means, see this. Here the soft tissue details are much lesser. I can show you. But the bones are very, very, even the thinnest bone are prominently seen. So even the thinnest bony erosions are very well picked up. But the soft tissue details, see in the brain, no soft tissue details are seen. On the contrary, this is soft tissue window. See in the orbit, everywhere, the soft tissue, this is soft tissue window. See now, infratemporal fossa, everywhere soft tissues are so prominent. Even in the brain, the details are seen. The soft tissue details are much better than the bone window. Let me put two together to differentiate. This is bone window on this side. This is soft tissue window on this side. Can you see the difference?
Yes, sir. Clear.
Orbit, brain, everywhere the soft tissues are better seen on the left side. See infratemporal fossa. But the bony details are much better seen on the right side.
Yes, sir.
So we must have both bone and soft tissue windows to give you even the finest of the bony erosions in that situation. This is
Okay.
very, very important to understand.
Thank you. Thank you.
Boss, good morning, Dr. Saurabh from
Sir.
Indore. Sir, just for the beginners, how can we differentiate radiologically in chronic allergic fungal sinusitis and chronic rhinosinusitis for the beginners, with the invasive fungal sinusitis?
See, that's a very important question. And the radiology has a big role in differentiating and overall surgical planning. Non-invasive fungus like allergic fungal sinusitis, they have more and more intrasinus component. We have a case today. That's why I have kept that case for demonstration. Non-invasive fungus means the fungus is more and more in the paranasal sinuses. You know? See this. Yeah. Let me show this. The fungus is occupying more and more paranasal sinuses, with widening of the paranasal sinuses, giving bony erosion, pressure erosion. Yes. See this? Most of the component is within the paranasal sinuses, and because of the pressure as the fungus accumulates, this material accumulates, it gives pressure erosions on the surrounding walls.
Yes.
But this is non-invasive because this doesn't invade the paranasal sinus mucosa.
Yes.
The basic definition comes from invasion or not invasion of the paranasal sinuses. How you pick up on radiologically is different. Radiologically, the non-invasive fungus will show more and more intrasinus component, less and less extra sinus component, and massive bony erosions because of the pressure. Got my point?
Yes.
On contrast, the invasive fungus like aspergillosis will have less and less intrasinus component. Sinuses are more or less empty, with some disease at one part of the sinus wall, eroding that wall, and a major component is extra sinus. Maybe in the orbital cavity, maybe in the brain, maybe in the soft tissue, maybe infratemporal fossa, whatever the adjacent cavities. So in invasive fungal sinusitis, there are two varieties. Mucor is a different ball game. Aspergillosis, chronic invasive, different. And that chronic invasive fungus will have less and less intrasinus component. The kind of sinus which is filled with the non-invasive fungus, you will never see in invasive fungus. Okay. So less intrasinus component, and wherever the sinus fungus is attached to the bony wall, will have adjacent bone erosion and more and more extra sinus component. The extra sinus component is more than intrasinus component. That is how you can differentiate the invasive from non-invasive fungus. Why this is important to differentiate radiologically? Yes. Because the treatment protocol is altogether different. For this non-invasive fungus, this is allergic fungal sinusitis. The treatment is removal of all this fungal antigen. Yes. Give wide openings to introduce steroid because this is allergic, which needs steroids. Yes. In contrast to this, in invasive fungus with a less intrasinus component, more extra sinus, the core treatment is medical. Surgery has hardly any role, but just to prove that it is invasive fungus, you need to take biopsy. The role of surgery is just limited to prove it by means of a biopsy. Yes. And then you can start voriconazole as a first-line treatment for the invasive fungus, that is medical disease, and whatsoever bigger extra sinus component, whatsoever big, the voriconazole, treats everything, cures. Okay. So that is how the difference between the invasive and non-invasive fungus, the diagnostic challenge and the treatment part is altogether different. So invasive fungus, hardly any role of surgery. Proving by means of a biopsy and then medical treatment. Non-invasive like this, on the scan, the treatment is more and more surgery to evacuate this fungus and establish ventilation drainage for the topical steroids, pathway for the topical steroid, and then topical steroid therapy, rather than medical antifungal therapy. Here in allergic fungal, there is no role of medical antifungal therapy. I hope you understood what I'm trying to say.
Yes, yes.
Any
Thank
other
you, sir.
question?
Sir, I think everything is absolutely clear. We're looking forward for the surgical demonstration. Really
Yes.
excited
So
about it.
let's go ahead. In a couple of minutes, I'll be with you with the endoscopic picture and we'll discuss the surgical nuances in detail. This decision making is very important. Radiology is very important to make your surgical course smooth, by means of minimizing complication as well and doing a comprehensive work rather than, keeping a fear in mind with no knowledge of anatomy and doing ultimately end up with an incomplete job. So the radiology has a big role. So in a couple of minutes, I'll be with you with the endoscopic picture. And
Yes,
we
sir.
can
Thank you very
continue
much.
our discussion and questions intraoperatively as well. Please feel free to interrupt me any point of time if you have any query or any suggestions.
Sir, what is maximum medical therapy before operating?
Maximal medical therapy means the medical treatment which can have an impact on the overall outcome. See, I told you this sinus disease, this eosinophilic disease, the core treatment is medical. This is a very important question. Core treatment is medical, but there are limitations. We know what weapon we have in the medical treatment by and large. Steroid. You give this patient oral steroid, he'll improve like anything. He'll come back to you showing gratefulness, doctor, what the drugs you have given me changed my life. Please continue with that. The previous doctor I went to, looks me very, very greedy. He was suggesting me surgery unnecessarily. And your medical treatment has improved me a lot. Please continue the same. Now, how can you continue? How long you can continue the steroid, oral steroid? In your hearts and hearts, it has its own adverse effects. So, the maximum medical treatment is limited to, not to the oral steroid, limited to the topical steroids. What you can give to improve the mucociliary activity? Saline washes. If there is secondary infection, you can give a short course of antibiotics. But the core treatment is topical steroids. Now, with all sinuses closed with disease inside, what topical steroid you have? Nasal sprays only. If you try to douche with the steroid washes, they're not going to enter the sinuses unless you have operated. So in an unoperated situation, you are left with a weapon of which can have an impact is topical steroids. And topical steroid which cannot enter within the sinuses. So hardly it is going to be effective. So in cases whether the disease profile is so low, wherein the topical steroids can be effective, you can continue with that. So as long as topical steroids control the patient's symptom, you don't need to operate. So the question of surgery comes when topical steroids are unable to control the disease, scenario, the massive disease. When you have a massive polyp, massive eosinophilia, what will topical steroid do? They cannot penetrate beyond anterior 1/3 of the nasal mucosa, nasal cavity. They cannot enter the closed sinuses. So what will topical steroid do? So there is hardly any treatment of, hardly any role of maximum medical treatment. Only in the scenarios of limited disease where your topical steroid can be effective to control the symptom, there is role of maximum medical treatment. And you can continue as long as you want, as long as the symptoms are controlled, because topical steroids are much, much safer. So if your nasal sprays can control, continue with that. Otherwise, you have to embark upon surgery to open up the sinuses to make sure topical steroid reaches within the sinuses. So again, the role comes of the main core of treatment is steroids, topical. The role of surgery to make the topical reaching within the sinuses. So without surgery, if your sprays can control the symptom, continue with that. That's the role of medical treatment. But in massive disease, they are not going to do that, not going to be effective. So ultimately, you have to operate. Got my point?
Got it, sir. Thank you.
The
Thank you.
role of
Sir,
surgery when your topical steroid cannot control the symptoms. So that can control only the limited disease.
Yes. So how do you see a role of steroid-eluting stents in pre-op settings or the post-op settings?
Pre-op, where will you put a stent? Your sinuses are closed.
Yes, sir.
Pre-op means your sinuses are closed. You have not opened yet.
Yes, sir.
So where will you put the stent?
So it's for the post-op management.
Post-op, it was device. See, the science is evolving. Everybody is bringing in something, revolutionary. So
Yes.
stents are part of that, and there's by and large the role of stents have been by and large declined for various reasons.
Okay, sir.
See, what would stents do? Like Propel was the one which was initially introduced. So it contains mometazone and it releases mometazone on periodical basis, topical mometazone.
Yes.
So like a spring-like action, you can insert after operating in the sinus cavity, you insert in the ethmoidal cavity. It opens up like a spring and it keeps on electing mometazone to keep giving topical steroids to the cavity. That's the role of the stent.
Okay.
So it was introduced initially and the cost was limited. The initial Propel probably $750 or so, US dollars. And it lasts for 30 to 90 days.
Okay.
So $750 for 30 to 90 days.
Okay.
And again, you have to insert it.
Mhm.
Secondly, it doesn't allow the steroid to reach in all paranasal sinuses like the douche reaches. When you douche, the steroid solution reaches everywhere.
Yes, sir.
The frontal sinus, sphenoid sinus, everywhere. The spring action of the Propel only opens up the ethmoid sinus. Then there are selective frontal sinus stents, sphenoid sinus stent with the cost and their limitation to keep, giving steroid, eluting steroid for that small area are not worthy, not so effective as the time-tested douching. We use the, rubber ball douching, which
Yes.
by means of pressure allows the topical steroid to reach everywhere in all sinuses.
Yes.
So the role of stents looks, fascinating, but not very effective. And that's why those who even started using have almost given up.
Yes.
Any other?
so I presume no questions. Sir, we can start off with the surgery
Yeah.
and then waiting for your demonstration. each
Yes,
and
yeah.
every-
And then we can continue the questions intraoperatively as well.
Sir, thank you.
Thank you so much for your attention. I'll get back to you within a couple of minutes.
Thank you, sir.
Yeah.
Now I request our organizing chairman, Dr. Smita Soni ma'am, to please felicitate the chairpersons, Dr. Sadat Qureshi sir and Dr. Vikram Kulkarni.
तो आप लोगों ने कॉल बैक करेंगे एक बार डॉक्टर पराशर करके उनका कोई पेशेंट आएगा तो
Thank you, Dr. Sadat Qureshi. Thank you, Dr. Vikram Kulkarni. Thank you, Smita Soni madam. Now I'll request Dr. S.P. Dubey and Dr. Anupriya Shah to take over as chairpersons for the next session.
I must congratulate Dr. Yashveer and
his team to organize such a wonderful show. And thanks to Dr. Satish Jain also, who has consented to be the operating surgeon online. And you have seen how he explained the CT scan in detail. And ultimately, you will see his master hands during surgery. And he will cover from basic to advanced. And I think most of the experienced surgeon as well as postgraduates are here. They are definitely going to benefit out of this conference. And I vouch that after this conference, they will become more wise to treat their patients. Satish sir, are you ready? Hello.
On kar.
So what
Hello.
other cases we have, Yashvir, now? After that?
Hello.
Yeah, Satish sir. Dr. Dubey
Good
here.
morning. Good morning, sir. आपकी आवाज से कौन नहीं पहचान सकता? So nice of you.
Then we are, I'm honored to have you in our MPENCON, and I am
Pleasure is
thankful
all
to
mine,
that you
sir.
are considered to be the operating surgeon. And there are a lot of experienced surgeon. Hall is full, and so many PGs are there to kindly teach us each and every steps in detail. And with me, Dr. Anupriya Hajela Shah is there for this session to chair the session.
Thank you, sir. Thank you so much. And indeed, pleasure is all mine to be part of this prestigious conference. And big thanks to you for involving me for this session. Thank you so much. So, we discussed before you came about the radiological part and some part of the decision making.
Sir, excuse me. Meanwhile, I'll request Dr. Anupriya Shah to say a few words regarding Dr. Satish Jain.
We all know Dr. Satish Jain is a surgeon par excellence who has performed and revolutionized the sinus surgery. And we are extremely honored to have you here, sir, at our 14th annual state conference. We welcome you here, sir.
Thank you. Thank you so much, madam.
Thank you,
What
sir.
we are you getting the picture on the screen?
Yes, sir. Very clear, sir.
So this is what you see, what we discussed, the massive polyposis in this case, bilateral polyposis, eosinophilic disease, polyps occupying the nasal cavity to give complete nasal obstruction. And what you saw was the unprepared picture. Now, once it comes to surgery, this endoscopic surgery requires proper visualization in order to avoid complications. As I mentioned, and we have seen on the CT scan as well, there are tigers around the paranasal sinuses, the orbit, skull base, carotid artery, optic nerve, and even a submillimetric disorientation can lead to fatal complications. So the visualization is the key. And in order to make this visualization more and more better, we have to improve our surgical field. In the sense, we have to minimize the bleeding. If there is too much of bleeding, the identification of the landmarks will be difficult. This is surgery of landmarks. You will see intraoperatively at every landmark, at every point, we will find a new landmark and will take the advantage of that landmark to progress further. So here identification of the landmark is the key, and that requires a good surgical field. So to improve the surgical field, our exercise starts days or couple of weeks before. What we all can do to improve the surgical field, as I said, begins even before the surgery. So in order to reduce the bleeding, we have to reduce the inflammation. This is inflammatory disease. And inflammation is because of eosinophilia. There is inflammation, vasodilatation, all this thing which contributes to more and more bleeding, and that too from the nasal cavity which is richly vascularized. So pre-operatively, we have to give couple of days a good course of steroids to reduce the inflammation. If there is secondary infection because of the blocked sinuses, because of the impaired ventilation and drainage, we can combine with a broad spectrum antibiotic as well to reduce the infection as well, secondary infection. So the main pre-operative part of, protocol to reduce the inflammation is steroid, steroid, steroid. That will reduce the inflammation in the mucosa. And same thing we have to continue intraoperatively as well. So the first thing what I'm doing intraoperatively, what you see on the screen is using the topical adrenaline carried in this soft marrow cell pieces to apply on the nasal mucosa to decongest the nasal mucosa. See this? This is how the capillaries are decongested. In this surgery, the major source of bleeding is capillaries, capillaries, and capillaries, not the big arteries like in tumors. Yes, sir.
Satish sir,
Yes, sir.
nowadays you don't use any pack, xylocaine adrenaline injection, which
Never.
we used to do. I mean, years together we have done this. In each and every conference, we will see that we inject in certain areas, then subsequently packed with xylocaine with adrenaline. So nowadays, what you do? You do
Yes.
only with Mirogel and
Yes, this topical
this
application.
wiping.
Topical application. Even I used to inject earlier, more than a decade, ago, and then we went to the literature. That same kind of field, what you achieve with the infiltration, injection, can be achieved with a topical medication, topical treatment, with certain help from the anesthesiologist, pre-operative preparation using steroids and other parameters. You can achieve the same field. So what all we do to achieve the same field, why we avoid infiltration? Because this adrenaline, if it happens to traverse in the systemic circulation, it can have deleterious effects. It can have even fatal effects which have been reported in the literature. In patients who are cardiovascular labile, even this systemic adrenaline, what goes with the infiltration, can lead to fatal consequences. So we don't want such consequences at all in this benign surgery, in benign disease. And because the same thing, same field can be achieved by other measures, you can easily avoid this infiltration. And it's been more than a decade we have been infiltrating in the nose for any region. Not only sinus disease, by skull base, septoplasty, anywhere, we do not infiltrate it at all. So what all measures together can lead to same field? One is, as I mentioned, pre-operatively using steroids along with sometimes antibiotics. Intraoperatively using topical adrenaline. See, the single application of topical adrenaline on the mucosa decongest the capillaries to prevent any systemic further absorption.
Even sir, for septoplasty, you are not infiltrating.
Not
Then
at all.
what you do to create the plane?
Yeah, you
You
can
will
inject the
infil-
saline for your
Okay.
hydrodissection.
So what is the concentration of adrenaline that you're using?
Yes, it depends upon the patient profile. In elderly patients, we use even up to 1:4 to dilute more and more, because elderly can be cardiovascular labile patient. In young patients, we do not mind even using pure or 1:2 combination. So it depends upon the patient's systemic profile and the age and all that. But whatever you use, see this, how you use is very important. I am just applying on the mucosa. That's it. I am not giving any pressure pack of the adrenaline. If you give too much of pressure, if you give pressure like this will rather be counterproductive in terms of giving venous congestion. And that venous ooze will be more frustrating than the capillary ooze. So don't use pressure, just apply, keep applying adrenaline onto the mucosa. That's it. Soft application, no pressure use, number one. Number two, to prevent venous congestion, you can keep your head end of the table by 10 or 15 degrees to facilitate the venous drainage of the head, to prevent venous congestion, because the venous oozing is most troublesome and most frustrating. Third is the anesthesiologist's help. That is very important. As I mentioned, this is in sinus surgery, the bleeding is mostly capillaries. And the capillary bleeding can be best minimized with the anesthesiologist's help by means of reducing the overall cardiac output. And that is best achieved by reducing the overall heart rate. Look at the monitor. We don't ask for the, see my heart rate. Can you see? 61.
Yeah.
So
Yes, sir.
keep the heart rate on the lower side to reduce the cardiac output. That's the only thing which we expect from the radiologist, from the anesthesiologist. Reducing the blood pressure or hypotympanic,
Diastolic or systolic pressure.
hypo or reduced
Hypotensive
blood pressure.
anesthesia.
Hypotensive anesthesia is not required. That can again put the patient who are cardiovascular labile at risk. Too much of reducing the blood pressure can invite cardiac issues in patients who are labile. So, we don't ask for hypotensive anesthesia ever in this surgery. Only thing we expect from the radiologist is to give us low heart rate. And see, this topical application of adrenaline doesn't affect the heart rate because it is not being systemically absorbed now. Single application decongest the capillaries and prevent systemic absorption. No heart rate change.
So
Any
can you use
reason?
Trenexa? Can you use Trenexa?
Pardon?
Can you use Trenexa?
Trenexa, a lot of publications that describe or assess the role of Trenexa. But Trenexa works by preventing, this fibrinolysis, and this surgery hardly has any effect on the use of Trenexa. I have no reservations to say no, you can use it, but it has hardly any effect. So we don't use it.
Sir,
This
any
topical
reason you are
preparation,
not-
the major thing which influences the surgical field or the bleeding, pre-operative steroid course, intraoperative topical preparation like what I've been doing for last 10 minutes, and the anesthesiologist help with reducing heart rate. These are three important, along with the head table rise, along with other things. These three parameters improve your surgical field like anything. Same what you achieve with the infiltration or even better, with much safety.
Sir, any specific reason we are not using topical decongestants?
Any specific?
Reason for not using topical decongestants like oxymetazoline, xylometazoline?
Oxymetazoline can be used. There is no doubt about it. That is also pretty safe. But see, we have to use this solution throughout the surgery at every level. That's why we prefer this diluted adrenaline. That is very good and safe. After the first application, no systemic absorption. So it is pretty safe. It can be used in any patient. There is no contraindication to use. What I am doing now, luminal work. See, you don't see any landmarks except the inferior turbinate and nasal septum now. So we have to discover landmark. This is a surgery of landmark. And see, this is the shaver microdebrider. And best way to use it, keeping the cutting edges under view.
Right.
This is such a versatile tool, useful tool, but can be deadly as well if not used properly. So start from below. What I'm doing is the luminal clearance. See this?
Right, sir.
When I'm close to the turbinate, keep your lumen away of this blade. This has a blade inside the blade which rotates and cuts away the tissue as well as sucks.
So very
These are-
important point for the postgraduates. Always see your rotating blades and always keep away from the turbinates and see how he is using, and there is no bleeding at all. Excellent.
So we can see more landmarks. We can see the nasopharynx. We can see the
Yes.
eustachian tube. And I am just using this blade to take away these polyps which are themselves jumping into the, blade.
Your blade, yes.
Normal tissue like turbinate or anything is never going to jump into it.
Now we are just going to see the landmarks also when you clear this.
So don't use it forcefully anywhere. Allow the
Right, sir.
tissue to jump and come into the blade. See this?
Yes, yes.
Don't forcefully try to insinuate this blade anywhere. See now, I can see the glimpse of the middle
Middle
turbinate
turbinate.
coming into the picture.
Yes, yes. Even we can see the glimpse of uncinate.
See, my
also.
cutting edges are in view, and I blade in the lumen, allowing the polyp to come and jump into it. See this?
Right. So it's a M5 of microdebrider, M5 handle.
Yes.
So it's a Zomad mad microdebrider which uses M5
Zomad is
handle,
standard.
which is costing more than 15 to 15 lakhs. And
See the massive
consumable-
polyposis.
Yeah. Even the turbinates are polypoid. This uncinate.
Everything. See now. We have, see my irrigation from my assistant is always on to keep the blood away. Can you see the field now?
Yes, absolutely clear.
See this. This irrigation should continue. See this like this. And now
Yes.
I have certain landmarks coming in my picture. Number one, this middle turbinate. This is key. An important finding to notice there is polyps medial to middle turbinate. See this?
Yes.
Yes, in the
Uncinate.
olfactory cleft.
Uncinate deformed because of massive polyposis in the middle meatus. The uncinate gets deformed. Uncinate we will identify. I'll show you how to identify the uncinate process. The deformed uncinate sometimes is difficult to, identify. I'll show you the way because this is a mobile structure. In the lateral wall, that's the only mobile structure as far as the landmarks are concerned. That is uncinate. Again, see, I am using the same marrow cell pieces. What you need to do is, what I have done, I have cut 2 marrow cells into 8 to 10 pieces, different size pieces. Can you see?
Yeah.
Use them. Then once you have used, remove them, squeeze them, then dip in the same saline adrenaline solution and reuse them. That's how you can reuse. Now again, see I have applied the adrenaline on the new discovered mucosal surface in the depth. Can you see?
Yes, sir.
Yes, sir.
This is how. Now, I mentioned one thing about that middle turbinate. Very, very important, finding I mentioned. Polyps medial to the middle turbinate,
Yes, in
It
the
has-
olfactory cleft.
it has immense significance. In the sense, polyps medial to the middle turbinate can give olfactory symptoms because they ultimately block the access to the olfactory epithelium. The air what you inhale is not able to reach to the olfactory epithelium. Got my point? And
Right.
such patients many a time present with a symptom of anosmia. Smell disturbances, number one. Number two, in such situation, at the end of the surgery, you have to ensure that your solution should reach the olfactory epithelium. What solution? Steroid. Got my point?
Yes.
This
yes.
loss of infection has 2 contributions. One is conductive loss, means your air is not able to reach to the olfactory mucosa. That is conductive loss. That you improve by making the, the nasal access clear by means of removal of the polyps. So what you recover is the conductive loss. Another component, because of the inflammation in the adjacent sinus mucosa, the olfactory mucosa also gets inflamed because of eosinophilia. And that mucosa also gets inflamed, leads to loss of function, that is sensory smell loss. Got my point?
Yeah.
So one is conductive component, other is sensory neural component like hearing loss. So in order to improve the sensory neural loss, what thing can work? Again, anti-inflammatory. Inflammation is affected So you need to introduce steroids. That's my point. And
Right.
in order to reach the steroid to the olfactory epithelium, what is most important? That's why I mentioned here, this middle turbinate becomes the problem. See this?
Yes, sir.
Because of the polyps medial to it, this middle turbinate becomes unstable. And this is one of the strongest indication I always mention for a partial turbinectomy. See this?
Yes, sir.
Open up this olfactory recess forever. So polyps medial to middle turbinate is the indication of partial middle turbinectomy. Strong indication in order to keep this olfactory access open so that the steroid reaches there effectively and can revert even the sensory neural loss to the olfactory epithelium. What my point?
Right, right.
So
Even in
important.
even in post-operative period,
Yeah.
your douche will also reach there.
Yes,
which you
so I
always
hope you
prescribe.
understood why I explained this. This importance of the polyp medial to the middle turbinate is very, very important in order to see how the surgical field is. Only with a topical.
Yeah, absolutely bloodless and
Bloodless.
clean.
Now, turbinate. What is that? Uncinate process. Uncinate
Is the only mobile structure in the lateral wall, as you said.
yeah. And see, here is the uncinate. This is my anteriorly the lacrimal prominence. This is not mobile. This is a thick
Right.
bone of the frontonasal process. And this is the fontanelle. And this looks me the uncinate. See this? The mobile
Yes.
structure. So the sometimes the uncinate becomes difficult to identify and you have to focus on it. What's my point?
And the ball probe is your preferred instrument, or you use sometimes backbiter after.
Yeah. Biting is much safer. Much safer in the sense you have to go back to the CT scan, why I'm saying. The upper part of the uncinate is the closest structure to the orbit,
Right, sir.
medial wall of the orbit. If you use thicker or anything, if it is too close to it, get accidental entry into the orbit, that too at the beginning of the surgery. And that is counterproductive. So in order to do that, you can use a reverse biting. So it is much
Right.
safer. Only thing you have to be careful about the anterior limit, that is nasolacrimal system. See now, I am using red 40.
So rate 40 is another blade of microdebrider.
Yes.
After state, he's using rat 40, which is curved, and you can see that he's
See, you have to, this is a very important tool. It doesn't take away the mucosa, it doesn't strip off the mucosa because it is sharp cutting.
yes.
This is the part of the uncinate which I am taking off, this one. So
Because
this
with
is a sharp cutting tool, is a very, very useful tool. It cuts the mucosa sharp but doesn't strip off the mucosa from the periost.
Right, with conventional instrument, you used to strip a lot of mucosa.
Yeah. You have
But
to
now
do-
if you want to do the surgery of sinonasal polyposis, I think, Satish, it should be a very, essential tool in the armamentarium of the
yes,
sinus
yes,
surgeon.
yes.
No doubt about it.
Person. See this?
Sir,
This size of enterostomy, there is always a question. A lot of time has been asked, how big the enterostomy should be. It is dictated by the disease profile. For a disease having massive eosinophilia, requiring massive steroid, topical steroid in future for long term, like AFRS, I would do mega enterostomies, to deliver more and more steroid effectively and long-term surveillance. For minimal disease profile, you don't need to unnecessarily make a larger enterostomy. So it is all tailor-made. It is all, a part of decision making that you have to take a call intraoperatively. See, I have put a marrow cell within the maxillary sinus. Okay.
sir,
Keep using topical marrow cell again and again to optimize your field.
See how patiently he is using since the beginning of the surgery, all the Mucosals, all the time swiping and getting the desired field, which you can see here.
More
From the beginning
important
of-
more important is not to use any pressure with the Mucosal. Soft application. You have to apply adrenaline on the surface, not the pressure.
Sir, even in Stemberger's period, era, they used to use pure adrenaline vial in Vienna
Yes.
to pack the
Yes.
nose in young patients. Even
Yes,
as you
yes.
said, that
Yes.
this adrenaline doesn't harm anyway if you apply topically until you don't inject it.
Yes. So as long as you are applying topical, it is safe.
Safe.
Now see, this is upper part of the Uncinate I was talking about.
So which instrument you are using, sir?
This is angle curate.
Curate. Okay.
See, in sinus surgery, any stroke which is away from the skull base or critical structure is safer. See what I'm doing? Going behind and fracturing it anteriorly. Can you
Right.
see this? This is
Sir.
away from the critical structure and I have fractured this unseen. See this?
Yes.
This is my turbinate and this is the axilla there, up. I'm
Attachment of the
fracturing it
middle term.
anteriorly and I told you this is very dull. This is one of the most important steps at this point at the beginning, as it is close to orbit. Orbit
Yes.
is your lateral limit of the entire surgical corridor. The moment I remove it, I will be at my lateral limit. See this? Now I have fractured, I am taking it with a microdebrider. I can use a true biter also.
So two side mucosa and in between bone you are removing.
Yes. So this is the Uncinate I am taking off.
So the laterally we are seeing the lamina papyracea, I think.
Yes. Now I am going to
Yes.
show you that. That's why.
Yes. It is
At
also
this step, you should be able to see the lamina. This is the lamina papyracea here. This is the lamina papyracea. See this white plate of bone. That is lamina papyracea. That's what I intended to see here. This is my lateral limit of the entire surgical corridor. If I keep this in mind and do not breach it, it will not enter the orbit at all. What my point?
right.
So
very
this is a
important
landmark. Yes, that you need to keep in mind always. See this? This is the, because of the polyps, even the your bulla becomes distorted. More polyposis, more bulla gets compressed. Sometimes becomes atrophic as well. So that is important. See the turbinate.
Yes.
This upper part of the turbinate is very important. I mentioned during radiology as well. This upper part of this vertical part of the turbinate goes above there to insert on the surface. On the lamina papyracea, so you have to handle it. This is your bulla modalis. I have
Yes.
removed the lower part of the uncinate, this part of the upper part of the uncinate. And this is axilla now. Can you see this?
Yes.
Now I am
Attachment of the
more and more reach the total process hard.
I think it's the excellent way of reaching to the frontal recess.
Yeah,
The
this
way he is.
I
is doing.
mentioned to everybody the simplest, easiest way to reach the frontal sinus is by following the beak.
Yeah.
See now what I have done? I have opened this space. You see very clear?
Yes, sir.
My all landmarks, and my so soft pakad. My all landmarks are in my view. See this?
Yes. Your middle turbinate in your view, laterally the lamina papyracea in your view,
Yes.
just below the maxillary sinus opening is in your view.
The
And
thing
by clearing the
that-
axilla, you can see the opening of the frontal recess also.
now I will go with a 70 degree up to show that. The important thing is my lateral is in my minor here. My medial limit is in my view, which is the middle turbinate there. And in between this corridor, I have to walk up along the beak to enter into the frontal. I mentioned again and again during radiology about the importance of the beak. So, everybody, whoever is considering the frontal sinus as a difficult sinus to deal with, follow this for a minute or two closely, how easily one can enter into the frontal without disturbing anything, that too at the beginning of the surgery, because the frontal sinus is most anterior sinus.
Yes, sir. I think all PGs should see how the frontal beak principle propagated by the Satish Jain is very easy to find the frontal sinus, which is supposed to be the one of the most difficult sinus.
Yeah.
You will witness now.
For anybody stuck in a frontal sinus work, now I'm using the 70-degree up. See this?
Yes,
And this is the interior of the maxillary sinus.
with 70, very nicely seen.
Yes. So, no. See, this is the interior of the maxillary sinus. The sinus mucosa is good, healthy, in the little congested heat matters that will revert with the establishment of the ventilation drainage. With the topical steroid going further, this will revert back to normal. So you don't have to, deal with the mucosa excessively. Allow it to revert back to normal. This boggy mucosa, inflamed mucosa is purely because of lack of,
Ventilation.
ventilation and drainage. See this? 70-degree, same picture. Now,
But it's
where I'm
30
looking
degree or
at
70 degree?
70.
70, okay.
Now, I have my lateral limit and medial limit in view, and see easily how you can go further. This is my lateral limit lamina. This is
Yes.
my medial limit turbinate. And this is the beak above. Can you see?
Yes.
I had shown umpteen number of times beak, beak, and beak during radiology.
So how you define beak for our postgraduate, sir? Please
Yes,
tell
that's
us.
what I'm showing you, going to show you. Very, very clear, crystal clear, no confusions at all. You can ask me 1,000 times, there should not be any confusion. Yes. So, what I'm going to show you is the beak now. Beak is what? Anybody, you're using this. This is the frontal process of the maxillary nasolacrimal duct. See?
Yeah.
And this goes above and broadens into the beak. This is above the beak. Okay? So this beak anteriorly forms the floor of the frontal sinus, and where the beak ends posteriorly is the drainage of the frontal sinus. Clear? Now,
Right.
this
So
thick
floor of
bone,
the
this is the
frontal
thickest
sinus
bone
is-
in the beak. How you identify the beak? Number one, your question, sir. One can easily identify the axilla. Can you see the axilla very clear?
Yeah, axilla, we can see.
No confusions?
No
This is
confusion.
axilla.
Yes.
Everybody. This is your
Okay.
lateral limit. This is your medial limit. Okay?
Yes.
Stay in between onto the axilla. If you stay between lateral and medial limit, it is very safe. Can you see the axilla? I will make the axilla row to show you something. That how thick the bone it is. See this thick bone, thickest bone. Can you see?
Yeah.
See the bone above my instrument.
Very thick bone.
Where this bone ends. Where I am? Where I am?
In the frontal recess.
This is frontal sinus in the depth. Can you see, sir?
Yeah. So I think the attachment of the middle turbinate is known as axilla. And at the attachment, you have a very hard bone and you have kept
Yes.
little bit behind and you enter into the frontal
And
sinus.
stay medial, lateral to the middle turbinate.
Okay.
Always stay lateral to the middle turbinate. What's my point?
Yeah. So that you cannot injure the skull base.
Now see, again what I had shown. Can you see the frontal in no time?
Yeah.
There cannot be any better or simplest or easiest way to enter into the frontal sinus than this. We have done
Oh.
thousands and thousands of such cases and came to this conclusion. See this again.
What angulation is this debrider blade?
This now I'm using 120. Earlier
120
was
degrees.
90, 60 degree, now 120. Let me mop this area and show you to recollect the landmarks, how we went inside. Look at the landmarks. This picture you should always have in your mind. You will never ever stuck in the frontal sinus work. In the safest region, in the safest way. Why I am adding this word again and again, safety. Everybody has a fear during frontal sinus surgery. There are a variety of fears. You know, number one, that I should not enter into the orbit. There is always a fear. What my point?
Yes.
Keep this lamina in view. This is lamina.
Yes.
And stay medial to it, you will never enter into the orbit. Fine?
Even Satish sir, any supra-orbital cells are there, we will not going to confuse.
That is behind the frontal sinus.
Okay.
I've shown
Right.
on radiology, clearly the supraorbitals are behind the frontal sinus. So, number one, safety with this procedure. If we keep the lamina in view, and if you don't transgrade lateral to it, this will never give any complication into the orbit. Number one. Number two, this turbinate is in view. I told you this turbinate goes above an insert on the cribriform plate.
Cribriform plate.
As long as you stay lateral to it, you are safe. Got my point?
Safe. Right.
Yes, sir.
Third is this direction with the 70 degrees. See this. I told you and measured with my cursor. This is the beak. Can you see?
Yes, sir.
I told you, if you remember, the cribriform plate is more than 1 centimeter behind the beak here.
Yes.
Got my point? While working along the beak in this direction anteriorly, you are miles away from the cribriform plate. I opened this frontal without any fear to the cribriform. If you remember, I showed you again and again on radiology.
Yes,
Remember?
sir. Yes, sir.
I measured again and again to show you that the cribriform is 1 centimeter behind the beak. Remember?
Yes.
Third. Fourth thing. This beak forms the floor of the frontal sinus. I showed you on radiology again and again. Follow the beak anterior to the posterior, where the beak ends is the beginning of the frontal sinus drainage pathway. Remember?
Yes, sir.
Now see. Now see. This is the beak. Can you see? I showed you the axilla. Can you see the axilla?
Yes, yes.
This is the thickest bone in the body here in this region. And in the axilla, stay between the lateral and the medial limit. Follow the beak, follow the beak, follow the beak. Where the beak ends is what?
Frontal
Frontal
sinus.
Where is the confusion?
No confusion at all
Confusion.
now.
No confusion at all. For anybody who is stuck in various calculation, or this building block, this cell, variety of cell, X, Y, Z, distances, this, that, forget
Full
everything.
cell.
We have done
Full
all
cell.
that. We have done all that.
Yeah,
You know,
yeah.
thousands of cases and came out with this.
And it's really more confusing than learning. Every time you have
Yes.
to learn all the names of the
See,
cell.
A technique can be good only when it is reproducible by everybody, not
Right.
by making it difficult. There is nothing hidden into it. Again, see this? No
Yes.
hidden concept. This is your axilla. Anybody can reach to axilla. In the axilla, this is the beak. Follow the beak, you are in the frontal. There is no more calculation. I hope it is very clear.
Yes, yes, sir.
Yes, sir.
Absolutely clear. And I think you have also, shown the path to go further if anybody want to do the lophrops or anything.
Anyhow, we
I
have
think-
case today, sir. I will show you
Yeah.
Lothrop. This is
Yeah.
the beginning, and then we'll go to the more advanced cases.
Okay, sir.
So, Lothrop, like you mentioned, is what? This beak is the problem in, reaching to the frontal sinus head on. See that? So if you drill away, your frontal sinus reaches head on. That is what Lothrop's or draft procedure is.
Yeah.
See the frontal sinus now, very clear?
Very clear.
Beautiful, sir.
Now,
And your
previous.
patience and gentle application of this Murogel really makes field absolutely clear.
This is required again and again. That's why
Yeah.
you asked me about the oxymetazoline. Cannot be used again and again like this throughout the surgery.
Yes.
See this? Now, widening the frontal. Now, once it comes to frontal sinus, there is always a question I have been asked. How big the frontal sinus opening should be? The frontal sinus opening, you cannot make wider than the natural one. So you have to reach out to the limits. What my point?
Yes.
In terms, widening is required not only for the establishment of the ventilation drainage, but at the same time you have to introduce the topical steroids later. So you have to have a good widen opening. So limits means now see where you can widen. Laterally, this is your lamina. You cannot go beyond that. Medially, this is your turbinate. You cannot transgress that. Anteriorly is one where you
you
can,
can
but you
widen
need to drill out. That is the indication for draft. Posteriorly is the skull base. What's my point?
Yes, sir.
Yes, sir.
Posteriorly, you cannot go beyond that. So only area which you can widen to access the frontal is anterior.
Yeah.
See
Yes.
this zone, your skull base is behind. If you drill in this region, there is no important structure at all.
Yes, sir.
In the next cases, I will show you drilling. No important structure at the most. Anteriorly, if you damage, is the outside skin, buttonhole the skin. That's it. But no critical structure. See, the skull base is more than a centimeter behind.
Yeah, absolutely safe.
So that is the safest region for widening the frontal. Now, posteriorly, what is the limit? I told you that is skull base. Now, see what I'm doing. To define my skull base limit, my skull base, I told you, is more than 1 centimeter from the beak. Now, I'm using the so-called adenoid blade, where my cutting edge is in view. Why I'm using with a 70 degree, it becomes front-facing blade. Can you see very clear?
Yes.
Again, always debride in the lumen, allow the tissue to come and jump into the blade. If you forcefully use it, you can damage anything. So always use in the lumen. Can you see this?
Yes, sir.
Yes, sir.
Keep widening posteriorly. This is how the frontal recess is widened posteriorly to the level of the ethmoidal
Skull
roof.
base.
Yes. See this. This is the maximum widening behind. And this is your, see this complete frontal sinus opening. I hope it is very clear.
Absolutely clear. No confusion at all.
So what we have done so far, we have done middle meatal enterostomy and we have done a frontal sinus work. And during this work, we didn't even bother to mention the anterior artery. Another fear people keep in mind while doing the frontal sinus work that I should not damage the artery. And we didn't even bother to mention about the artery. Got my point?
Yes.
The reason is, दूसरे को under करो.
Intact bulla.
Bulla. The artery is, I will go back to the CT scan and show you how far the artery is from the frontal sinus. I told you this skull base, this ethmoidal roof is 1 centimeter behind the beak. I
Yes.
told you from the beak, the skull base is more than 1 centimeter behind. And from here, the vessel is another more than 1 centimeter behind. So where is the question to mention that vessel unnecessarily?
Yeah, it's my.
That is far more safer, far more behind the beak. So I didn't even bother to mention about safety of the vessel. Get my point?
Right,
And
sir.
what is given additionally, this bulla. Majority of the time, this bulla goes above to insert on the ethmoidal roof, skull base. See this? This
Yes.
bulla goes above and insert, and the artery remains behind the bulla, traversing through the skull base. I told you this vessel traverses through the skull base. What's my point? And
Yes,
this
sir.
bulla cover. So we didn't bother to dismantle the bulla, and vessel is automatically behind that. And more than that, the vessel is more than 2 centimeters behind the beak. The skull base is more than 1 centimeter and vessel is 2 centimeters. Got my point?
Yes, sir.
Now, at this point, let me show you. And in this particular case, fortunately, the vessel is not very prominent. We have seen. See this?
So again, you are breaking the bulla from behind front.
Yes. Yeah. The bulla is not very big one in this case because of the polyps. It is
Polyps.
compressed. Anyway, stick on the posterior surface and fracture it out. Sticking on the posterior surface, sticking not on the skull base. What's my point?
Right, sir.
This 60 this. Patla de na. Let me show you something important here. See, this bulla is compressed because of the polyps.
Yes, sir.
So you have to be careful in that, addressing this fact.
Because again, the lateral margin is lamina.
Lamina. Yes.
Yes.
See now. See here. The vessel is far behind. And this is the upper attachment of the bulla there. See this upper attachment I am taking off. Medially, until the turbinate, I can remove all these septations. See, this is model skull base. See carefully.
Yes.
And always use your micro debrider in the lumen. This is very important for people who are using micro debrider, not push anywhere. See now, a lot of landmarks have opened up, which I am going to show you. Let me just debride these polyps for a while to open up the landmark. See, I am working in the lumen, not at the limits. I will show you something important. I am opening up all these septa I am removing till skull base,
Yeah. Sometimes these osteotic bone becomes very thick.
Yes.
These
it becomes-
septations.
Can you see something? Give me the. See your ethmoidal skull base. After removal of the bulla, your ethmoidal skull base is pretty clear. See this? See right the slope from the
From
frontal
frontal up
sinus to the ethmoidal roof.
ethmoid. Yes.
Let me decongest reverse.
All the mucosa are clear here.
Don't denude the bone. If you denude the bone, then it will not heal easily. The raw bone will invite
Granulations.
fibrosis, granulation, crusting, infection. And then it is not fast, it is mess.
So always preserve the mucosa.
And that happens when you use the micro debrider, when you use only in the lumen, not
Yes.
on the surface. Don't press it on the surface. See the mucosa everywhere is preserved.
Yes, sir. Very nice dissection. I think message to all our PG colleagues that always work into the lumen, not touching to the
Don't press on any surface.
yes. So it's clearly visible from frontal up to the
Say
ethmoidal
this.
roof.
Now, I told you this patient's ethmoidal roof is very thick, not very pneumatized. Your vessel is not very prominent. Let me show you the area of the possible area of the ethmoidal artery. See, this is your frontal recess. I am using reverse. Can you see?
Yes.
Yes, sir.
This is all mucosa. Only this prominent bone, this below this mucosa,
Yes.
that bone belongs to the anterethmoidal artery. It is not very prominent. I knew from the CT scan, I told you, it's not prominent. But see, this is skull base, this is the beak where my blade is.
Yeah, yeah.
This region is more than 2 centimeters behind. So don't terrify with the anterethmoidal artery. This is much behind on the skull base, right here. See this here.
Yes.
It is far, far off from the beak in terms of distance and direction. Can you see that?
Yes, sir.
It is not prominent. This is here. And so this comes out of the orbit, goes obliquely like this here and enter the cribriform plate. See this? Again,
Yes, sir.
here it arises from here and goes, leaves the orbit and goes to the cribriform here. So this area of the cribriform here is the thinnest part of the skull base.
Right.
And this area is more than a centimeter behind the beak. So while working for the frontal sinus anterior, you don't have to get terrified with any of these.
Right.
The cribriform plate as well as ethmoidal artery, both are behind, both are posterior structures compared to the frontal sinus and beak. That's what the message I want to give you, because this fear of these two structures make the surgeon doing incomplete. So these are all posterior structures. See the artery here, far behind, and the beak is here. Got my point?
Yes, sir. But when we see the Kiro's classification, according
Yeah.
to that, in which classification, in which segment we have to be keep more vigilant, and we should not go more medially.
This region, that's what I'm telling
This
you.
region.
This
Yeah.
part here, where this artery enters the cribriform, this here. And this
Okay.
is more than a centimeter behind. This is much posteriorly right at the skull base. I can manipulate this part of the turbinate anything, but not here.
Yes.
I can remove this part of the turbinate, this lower part of the turbinate I am going to remove. Only this part you have to respect, this part. That is very close to the cribriform attachment.
Right, sir.
Okay?
Sir.
Having done this, now I'll change to 0 degree again. Any questions? Anything you want me to show again? Please feel free to comment or ask me. Now I'm back with a 0 degree one. For your reorientation,
We can see all the landmarks very clearly, except we see the polyps medial to the middle turbinate.
medial to the middle turbinate. That is making
Yeah,
middle
sure.
turbinate unstable, and we are going to address that.
Yes.
That is my strong indication for a partial turbinectomy.
So the whole nasal cavity is very quiet and calm, not looking very angry, aggressive, like we see sometimes in our surgery, a lot of bleeding, packing, all the mess. Thanks to, I think, your technique of gel form swiping regularly during the surgical procedure.
Sir. Now, coming to your point, the polyps medial to the turbinate. See this. And Massive polyposis medial to it. See this?
Yeah. Sometimes when the conventional teaching was there that you have to reach the sphenoid sinus, then you go infromedial to the middle turbinate.
Yes.
I think in that case also we can
Yeah.
likely to injure the
I am-
skull
I am
base
go-
or
Yes. I'm going to that point, sir. That's a very important point. Yes. See now, the part of the polyp which I have debrided. And see, the polyp medial to turbinate always makes the turbinate unstable. See this?
yes, sir.
If you don't partially, cut this turbinate, this may collapse laterally and block the cavity.
Yes, sir.
Your entire purpose of, irrigation is defeated with a simple mistake. Now, we have done maxillary sinus, we have done frontal sinus, we have done anteriothmoids.
Sir.
What all sinuses left are the most important ones? The post-ethmoid and,
Sphenoid.
100 years ago, more than that, there is a dictum which was described by the Mosher long back. The easiest way to kill the patient is a ethmoidectomy.
Sir.
Why? Because while doing ethmoidectomy, if you are not careful and keep going behind, one can go and damage the carotid artery in the sphenoid.
Correct.
When you are not aware where to limit posteriorly. Got my point?
Sir.
Now see, I
And sir,
told you,
people- And sir, people used to say previously that always you begin with the posterior to anterior, because if you do the frontal sinus work first, then all the time blood is trickling into your field. But you have done the reverse. You have done the frontal first, then you are going behind.
those things can be overcome. Those are small issues one can overcome. That
So there
come
are
from
two big rhinologists who have given anterior-posterior or posterior-anterior.
that is
Vigand, I think.
that kind of teaching now I would say is obsolete in this era.
So there are
Now-
so many concepts which have changed now. I think frontal sinus, which was the most feared sinus, now with your beak identification technique has become very simple.
Sir. Now see, I told you this turbinate is floppy and this is access to the olfactory axis behind. See this?
Yeah.
Now in this upper 1/3 of this turbinate, upper 1/3 here, even this adjacent mucosa on the turbinate is olfactory one.
Okay.
This uppermost part of the septum has olfactory mucosa. Can you see the change in color of the mucosa?
Yes, it is
Yes, sir.
becoming
On the
little yellow.
septum. On the septum,
Hmm.
this uppermost part is olfactory mucosa. This upper 1/3 of the turbinate adjacent turbinate has olfactory mucosa. I'm not going to disturb that. But my point,
Yes.
so that you don't violate the olfactory system, at the same time, you open up the olfactory access for the topical steroids.
So, sir, for juniors, how to have the landmark? Because sometimes when you are showing us first olfactory nerve, or with your, what criteria you have used to where to cut the middle turbinate?
So that's
By
why
the
I
color
told you
of the
roughly,
mucosa?
this upper 1/3 stump of the middle turbinate should not
Okay.
be disturbed.
Right.
See, this is lying along with the septum. This is not going to fall off and block the entire throat cavity. See this?
Yes.
And this has opened up the olfactory access clearly from below. So upper lower 2/3 in situation when the turbinate is floppy and there are polyps medial to the middle turbinate, this lower 1/3 has to be resected. Otherwise, it will become a source of problem. See this?
Sometimes we see the whole of the posterior part becomes polypoidal.
I will show you the example in one of the case today, how the turbinate can spoil the life of the surgeries. We have a case today, I purposely kept that. See now the entire olfactory cleft has opened up.
Sir.
The whole goal is this olfactory mucosa should receive steroids. See that?
Yes.
Yes,
To revert or treat that sensory neural hearing loss, this olfactory loss because of the inflammation in the olfactory mucosa. See this now. Once I remove this, see this now, entire olfactory region will receive steroids. See this?
Yes.
It has been opened like a book. See this olfactory region, this one.
yes, sir.
Hello?
Yes, sir. Yes, sir. All your douches will reach there and patient will smell
Yeah,
nice.
that's the only thing. At the same time, the turbinate will not block the olfactory, but the ethmoidal access as well. And this upper stump will always be helpful in identification of the frontal region. So this way your anatomy is still maintained, you know. Now,
Sir.
we have seen the post-ethmoids. I have not done post-ethmoidal dissection much, just opened. My concern is, while doing this post-ethmoidectomy here, if I keep going, I never know where the optic nerve and carotid artery can come. Got my point?
Yes.
So I have to, discover some landmark to give me added safety. And see, my landmark is, the best landmark is the ostium of the
Maxillary
sphenoid sinus. Sphenoid sinus. The sphenoid ostium is my last landmark because if I follow the sphenoid ostium and go behind, the carotid artery, optic nerve, any structure in the extreme of the anatomical abnormality cannot come anterior to the sphenoid ostium. The reason behind considering sphenoid sinus ostium as a landmark, again what I'm saying, as long as you stay anterior to the sphenoid ostium, your carotid artery, optic nerve cannot come anterior to you. Got my point?
Yes, yes.
That's why I'm very, optimistic for the sphenoid sinus ostium to be a great landmark. That's the greatest of the landmark in this region, I would say, and the most reliable one. See this. How to discover the sinus ostium? Again, I have two landmarks. See the roof of the maxillary sinus here. Can you see here?
Yes,
Yes.
Sphenoid sinus ostium should be traced at that level or below. Why I'm saying so? This is again very important. If you don't take this into consideration and try to look for the sphenoid sinus ostium above, one can easily breach the skull base and go in middle canal fossa. So while looking at the sphenoid sinus ostium, you're not supposed to go above the level of the roof of the maxillary sinus or the orbital floor.
Yes.
Got my point? Second,
Yes, sir.
this is your superior turbinate.
Superior turbinate.
You have to stay below this level, medial to it, and along the septum. Along the septum is the key. If you go along the septum, you cannot damage anything. That is too medial. Can you see the ostium?
Yes, sir.
See this. Do not go below this level. See again. Stay lateral to the medial to the superior turbinate and go flush with the
Septum.
septum. See this. Literal meaning flush with the septum. See this. Can you see?
Yes, yes.
Not flush with the turbinate. You can go literally. Go flush with the septum and below this level. Again and again I am saying this fact. This is the safest way to reach out the sphenoid sinus ostium. Got my point?
Yes,
Yes,
sir.
sir.
Below the orbital floor of the roof of the maxilla and along the septum. Flush along the septum. If I don't follow this and try to go above, one can breach the skull, and that's a disaster. Okay? Now,
Sir.
why I opened the ostium? I have done my post-ethmoidectomy yet completely. anything anterior to the sphenoid ostium, I can debride. What's my point?
Yes.
After finding the sphenoid ostium, I am doing my post-sigmoidectomy. That is the key. And removing this lower 1/3 of the superior turbinate. Lower
Superior
1/3
turbinate.
only. Upper part is a olfactory mucosa. See this? This
Yes.
is my post-sigmoidectomy done. Anything anterior to the ostium, one can easily remove. Because anterior to the ostium, laterally, the optic nerve carotid artery can never come. See this?
Yes, they are behind it.
Behind it. That's the role. Now, this is the party wall between the ethmoid and the sphenoid sinus. I am widening.
Yes.
You can widen with a side punch. You can widen carefully with a micro debrider, keeping the cutting edges in view, not to go too deep. See this?
Yes.
All this anterior to the sphenoid ostium, I can remove.
Yes.
See
it's
this?
all behind.
All this, my limit is anterior to the ostium. This is ostium, and anterior to this, the entire post-sigmoidectomy done now. My post-sigmoidectomy is complete now, after the sphenoidotomy. See this? And I
Yes.
can widen my sphenoidotomy under vision to the lateral wall, under vision. See this?
And all your washing will reach also
Yeah.
to this
Inferior,
wider is
you are not supposed to go too inferior. Otherwise, one can reach damage the septal branch. See now, this is my post-sigmoid. See carefully where my blade is. And this is my sphenoid. See that?
Yes.
Can you see both the cavities separately? This is your skull base. This is your frontal sinus, ethmoidal skull base, post-ethmoidal skull base. See this? And then is the sphenoid. Widened sphenoid. Can you see?
Yes, sir.
And I am not damaging anything in the upper part medially because olfactory mucosa is there. But the access to the olfactory mucosa is completely opened up like a book. See this?
Yes, sir.
So this completes my sinus surgery on this side.
So you douche with the budesonide respule. Kindly tell your protocol to all our delegates.
Yes. So one of the goals for this sinus surgery, we have multi-pronged approach to this, disease, and sinus surgery has a big role. And sinus surgery is three main, goals. Number one, to establish the ventilation and drainage of the sinuses by means of widening their ostium. We have achieved
Yes.
for their good health. Number two, we have removed the polyps or any mucin, whatever, that is the inflammatory disease. So we have removed the disease load. Got my point?
Yes, sir.
The disease load is reduced to the minimum that the oral steroids are not needed, the topical would be sufficient. Got my point? And
Yes,
third is, we have given wide access for the topical steroid to reach to all sinus mucosa, which is the destination for the treatment. See this, all sinuses have been opened wide. You
So
now
you
do.
always say that this polypoidal disease is a medical disease. By
Yes,
doing surgery, we are facilitating drug to go there. So
Yes.
that is how we explain to our patients also. na?
patients. Yes, that is sometimes difficult and you have to explain them. Let me give you an example.
Yes.
Because the first, your question is valid because the first question of the patient now, because most of the patients nowadays have a habit of Googling. The
Yes.
first question comes from, Doctor, I have known that this disease is notorious to come back and I need to get this surgery again and again done.
Hmm.
You have to agree with him. Yes, this is notorious. So the surgery is not the end of the treatment. That is what you need to counsel. If you
Yes.
counsel your patient that we will do your sinus surgery and don't worry, you'll be all right. This is the biggest joke one can crack.
So
You have-
remember, this is a lesson for all promising surgeon that this surgery will not cure your disease.
Yes. This
And
is a
though-
step towards treatment, definitive treatment, step towards definitive treatment. So you have to counsel your patient, look, your treatment of this disease is medical, and that is steroid. I can give you steroid, you will do very well. I am quite sure about it. But the problem is steroids have their own adverse effects. We cannot continue that for life.
Yes.
So we have to develop some strategy to avoid oral steroids. And for that, sinus surgery has a big role. So once we operate, you will no longer need oral steroids frequently. You may require in case of exaggerations, but very little. And if you follow the post-operative protocol of topical steroid judiciously, the need of the oral steroids will be much, much less and less, or will be no need most of the time.
Sir, I
So
have a question.
my
So how
surgery will make the need of oral steroid to the topical steroid to much safer, because topical steroids, even delivered in high doses, have hardly any systemic absorption and are pretty safer. And it has been proven by long-term studies, years and years together, the topical steroids have found no effect on the hypothalamus pituitary axis, HPA axis. So the goal of surgery is to make the topical steroid reaching and switching over the oral to topical steroid. So don't think that the surgery will cure you, but surgery will make your life easier by avoiding the need of oral steroid. Yes, madam.
Sir, I have one question. Sir, supposing you open the sphenoid and you find pulsations over there. Recently, we had a case where we didn't suspect any kind of blood vessel to be nearby, but when we opened the sphenoid, we found there was marked pulsation. So does that mean that we've gone in the wrong plane or we've eroded something?
See,
It's a
pulsations
very
have many
scary
regions. Yes, madam.
inside the sphenoid sinus.
Yeah. So pulsations have many regions, yeah, when you observe in the sphenoid sinus, and that your CT scan can tell you before even.
No, the
So-
CT scan didn't tell. We didn't suspect at all that there would be anything.
If your all bony margins intact all around, that means your clivus is not dehiscent, your carotid is not dehiscent, then you will not perceive the pulsation. Pulsation could be because of, at the lower end, there is a small vessel here. That is the, the septal branch. That's a tiny vessel, not a big one. Otherwise, there is nothing more to pulsate. But yes, many a time there are clival dehiscences, there are carotid dehiscences which can contribute to pulsation, and your pre-op CT scan can, warn you.
So how
Yes.
wide should you open the sphenoid in such cases?
See this? Wide. My medial limit is, I already went flush to the septum, and lateral limit is the lamina papyracea. Can you see this?
Yes, sir.
Inferiorly, I am not keen to widen it much more. I can do a little bit more, but in case if you really have to widen more inferiorly, you have to elevate the mucoperiosteum, because one can unnecessarily damage the septal branch otherwise.
Branch.
You can, widen inferiorly without damaging the branch. What you need to do is, let me tell you. See here, in this mucoperiosteum runs the branch. What you do is, elevate this mucoperiosteum from the bone. Elevate this mucoperiosteum from the bone and then punch the bone. That way you can easily save the branch. Okay? And
Yes.
see,
Sir.
sometimes you have a polypoidal disease within the sphenoid. See what the blade I am using? Curved blade facing anteriorly, and you can even debride the polyps very clearly. See this? It is the direction of the instrumentation which matters. Under vision, keeping your cutting edges under vision. See the sphenoid now?
Yeah.
And once you don't have to chase all the thickened mucosa or boggy mucosa. Once your steroids starts going inside, it will revert everything back to normal.
Sir, how long you advise this nasal douching? Is any
Yes.
in between holidays for this douching? How you explain your patients?
So we'll not show on the other side. I'm coming to your question, sir. We'll go into
Okay.
the other case. So coming to your question, how long one should douche? This is the $1,000,000 question. The reason behind this question is again asked by all patients. When you tell them that after the surgery you have to start douching,
Yes.
you know, this is the same question like patients ask who have malignancies that you will do this primary resection, secondary resection, metastasis and all that. And patient will ask, doctor, will I need any further treatment? So it is always dictated by the underlying pathology. Try to understand what I'm trying to say.
Yes, yes.
This post-operative treatment is dictated by underlying pathology. Now to understand better, we have discovered variety of endotypes of sinusitis. Variety of endotypes. Each endotype has a different underlying pathophysiology. For example, AFRS, our next case, has a different underlying pathology that is pure antigen-antibody reaction. And for any antigen-antibody reaction, the treatment of choice is steroid. So in AFRS cases, the patient will need long-term steroid, maybe lifelong. Another variety is AERD, aspirin-exaggerated respiratory disease, which aspirin reaction is the culprit, making more and more leukotrienes and giving massive inflammation. That is the highest grade of inflammation in sinusitis you observe in an endotype that is known as AERD. Massive eosinophilia and massive leukotrienes. And that requires highest dose of topical steroids, So endotype dictates, number one. In AERD, since it is the highest level of inflammation, in order to ensure that your topicals reach effectively everywhere, on a primary basis, even when not needed, we do a draft 3 so that the frontal ostium doesn't get narrowed and the topicals reach in the frontal sinus effectively. So you have to take the steps accordingly. And in those patients to revert the underlying pathophysiology, you have to desensitize with the aspirin. Unless and until you don't desensitize, you have to use steroid topical lifelong. Unless and until you do not revert the aspirin sensitivity, you have to use more and more steroids lifelong. So depending upon the underlying pathology, the steroid will be needed, number one. Number two, how to track this? Sir, your second part of the question I am making, how to track how much of steroid is needed? Hello?
Yes, sir. Yes, sir.
Hello?
Yes, sir. I am listening.
Jainira? Hello?
जा रहा है सर, आ रहा है, आवाज आ रही है आपकी.
Hello?
आपको हमारी आवाज नहीं आ रही?
We are listening you. Please continue. Dr. Jain.
नहीं, जैन साहब को नहीं जा रही.
Hello?
हेलो.
हेलो.
हाँ, जैन साहब.
हेलो.
हेलो सर, आपको आवाज नहीं आ रही?
फोन करो ना यार.
Hello. Sir.
Could you hear me?
Yeah. We are continuously listening to you, sir. I think in between you lost our voice.
Yes. So,
please.
Practically, how to track how much of the steroid is needed? So, post-operatively, you have to do periodically nasal endoscopy to look at the mucosa. So, like initially, according to disease profile, we start with a pudendocide respule, like 0.5 milligram topical per day. By mixing in the steroid, saline and douching, total dose 0.5 milligram a day. That too is topical. In 6 to 8 weeks, the mucosa should revert back to normal. Now, according to the mucosal condition, you can keep reducing the frequency as well as concentration of topical steroid. What my point?
Okay.
You can reduce the frequency of the douching phone. Na?
This in addition to the steroid nasal spray, sir?
Madam, steroid nasal sprays do not cross beyond anterior 1/3 of the nasal cavity. Once you have opened all the sinuses, now you have to introduce steroids in the depth of the sinus mucosa, depth of the frontal sinus, sphenoid sinus, maxillary sinus. How will the steroid sprays will reach?
Yes, sir.
And sir, is there any specific positions you
Yes.
advise to your
Yes.
patient
Yes,
so
I'll come
that
to it.
this fluid should reach everywhere?
Yes, I will come to that. So
Yeah.
coming to the madam's point, what raised to everybody, there is big no role of steroid sprays post-operatively. Forget about it. Now you have opened the highway for the steroid to reach in the depth of the mucosa. What is the fun in using steroid sprays which do not cross beyond the anterior third of the nasal cavity? In the pre-operative conditions, when the sinuses were blocked, unopened, that time was the douching had no role. Douching would not reach inside the sinuses. And then the only limited, steroid what we had in our weapon was the steroid spray. What my point?
Right.
Yes, sir.
Once you open the sinuses, now comes the role of douche. That's why we opened the sinuses, so that we can introduce the steroids in the depth of the sinuses.
Yes, sir.
So once you open, there is no role of steroid sprays. Forget about it forever. Number
Regarding
two.
positions.
Yes. Before that, so I told you after 6 to 8 weeks, according to the mucosal condition at the time of healing, according to the healing, you can keep reducing the frequency and concentration of topical steroid. Concentration means 0.5 milligram per day, you can reduce to 0.25. Frequency twice a day to once a day. Again, follow up after a month or two. If the mucosa looks healthy, you can keep further reducing. Number one. Number two, I mentioned in the beginning, this is like a syndrome. Anything, any comorbidity which affect the sinus disease has to be assessed and treated at the same time parallel. For example, many of these patients have allergic rhinitis. And if the allergic rhinitis, again, we all know is a medical disease. It's a medical disease. Even after a good sinus surgery done, if the patient develops significant allergic rhinitis, he will develop the same symptomatology and he'll affect the same mucosa. That will affect the same mucosa. And patient will perceive the same overlapping symptoms of obstruction, sneezing, nasal discharge. And patient can come to you and say, doctor, your operation has gone complete failure. I developed the same problem again. So you need to understand that is not a failure. That is failure of, assessing the comorbidity and not treating that. So you have to, the onus is on the surgeon to assess all the comorbidities which can affect the outcome. So you have, if the patient has associated allergy, you have to counsel them before surgery that post-operatively will treat at the same time allergy along with. We may need allergic testing, skin prick testing. We may need immunization or whatever anti-allergic treatment in the future. Otherwise, can give you same problem. If the patient, I told you this is an immune complex disorder. Sinus disease is immune complex disorder. That is the sinus mucosa immunity is affected. The mucociliary activity is affected. That is the reason behind this entire problem. So if the patient has any systemic immune disorder, you have to assess that before and treat accordingly parallel. By and large, anything which has a negative impact on the immune status of the patient will have a negative impact on the overall outcome of sinus disease. Your sinus disease can result into utter failure if you can't improve the immunity. Whatsoever you do, the symptom will and the problem will persist. So
Sir,
you have
one
to
question,
assess.
sir. Sir, you
Pardon?
told respules. Respules
Yes.
use करते हैं आप. तो
Yes,
कौन
ma'am.
से respules use करते हैं?
Good
Beauty
enough
cord
time.
लेते हैं
Budonosides are water soluble,
Okay.
like the budonoside used for inhalation for asthma patients by pulmonologists, the same budonoside respules.
Any more, sir? Butycot तो हो गया अपना. कोई anti-allergic targeted?
No, anti-allergic has no role in the entire treatment of
Okay.
CRS.
ठीक
See,
है. So
what
Butycot
do
is good enough.
anti-allergic do? Anti-allergic competitively bind the histamine receptor to prevent allergic response. CRS has nothing to do with that. There's no role of anti-allergic at all. Anything improve the immunity has a big role, like lactobacillus, anything which has a positive impact on the immunity will improve the sinus
Or
disease.
sometimes these macrolides for long-term use.
Macrolides have a big use in non-polypoidal disease, non-eosinophilic disease.
Okay.
Macrolides are wonder drugs, have impact on many things. So in patients who have non-polypoidal sinusitis, no polyps, yet sinuses full of disease, having symptoms of non-polypoidal sinusitis, there is no point in operating first hand. You start on long-term low-dose macrolides. They have effect on various cytokines involved in pathogenesis of non-polypoidal sinusitis. And majority of the times you don't need sinus surgery. You can revert the sinus disease only because of only with the use of macrolides. So, but
Sir, how often do you do
with
desensitization of your allergic cases? How often do you require?
all
to do
allergic patients should be
You
assessed.
do.
Yes.
And
Sir, how often
how
you
much
do?
after that? How much days after surgery do you go for this desensitization and all?
After a month or so, when the healing has taken place, see, your topical steroids are already going in meantime,
Hmm.
and that will contain the allergy on their own. So as long as topical steroids are there, they contain the allergic process as well as in control, you know. So after 4 to 6 weeks, when you think of reducing the frequency and duration of the,
Steroids.
steroids, and patients who are allergic, you need to test with the allergic testing.
And sir, how often you do aspirin desensitization in your practice?
Yes.
How often?
Very often. And there are patients for that. Not every patient requires,
How to find out? You send all the cases for histopathological examination. How you define between AFRS or AERD?
Yes. So your question is valid. Which patient we select for sensitive aspirin desensitization?
Hmm.
Clinically, you have to be highly suspicious over patients who have polyps along with asthma. Those are the patients who are likely to be aspirin sensitive. What my point?
Yes.
This is a triad. Patients with polyps, if have concomitant asthma, I will keep a track for the aspirin sensitization. Close watch, number one. With further history, if any history of reaction to the painkiller, that substantiates your finding that patient could be aspirin sensitive. What I mean to say is, patients with polyps and not having asthma, there is no point in thinking towards aspirin sensitivity. What my
Okay.
point? Only that 10% of the patients of polyps having asthma can have aspirin sensitivity. You have to track on that. And in those patients, you have to keep an eye for the aspirin sensitivity. If they are sensitive, they need desensitization. Desensitization means active aspirin desensitization. You have to give them aspirin. So that can be given. Aspirin is a blood thinner. You cannot give pre-operatively. So once the cavity heals completely after 4 to 6 weeks, then you have to keep those patients for aspirin sensitization. First testing, on skin prick testing, if they are positive, then you have to admit them in intensive care setting. We do with a pulmonologist in intensive care setting for the desensitization. So in that, we have to start with a low dose of aspirin. Low dose of the aspirin, where the patient is sensitive to, will immediately give, it will blast the allergic reaction. The patient will have immediate rhinorrhea, nasal blockage, sneezing, severe asthma, all that. That's why the patient has to be given this in ICU setting. And patient develop this symptom in ICU. Accordingly, the pulmonologist or intensivist control the symptoms by means of giving steroid, by means of giving Montelukast, by means of giving, sometime this thing, inhalation, by means of giving nebulization, by means of giving, in extreme situation, adrenaline as well. Once comes under control, increase the dose of aspirin after a couple of hours. You started with a 30, now start with give 60. Patient will again develop the reaction. With increasing doses, this aspirin sensitivity has a classical feature of, tolerance. With increasing doses, you have to control the symptoms of reactions, and with increasing doses, the response of allergy or the reaction is blunted. In a day or two, we are able to reach to 30, 60, 90, 120, 240, 320, like that. Up to 600 milligram of the aspirin, one can reach with the patient start tolerating. And that is what desensitization is. When patients start tolerating high doses of aspirin, what does it mean? Now, no more reaction to aspirin, no more leukotrienes are forming. Now, the favorable prostaglandins are forming by means of metabolism of aspirin. And in that situation, the entire, the pathophysiology of the sinusitis is drastically reverted. So those patients require aspirin for life to keep the leukotriene under control. So with period of time, we keep on reducing the doses of aspirin then. And majority of the patient, we are able to bring the aspirin to 100 milligram a day for life. Aspirin is commonly used for lifelong treatment for cardiac patients, suspected cardiac patients, and many other atherosclerotic and other patients, Same way, aspirin sensitive patients require, after desensitization, low doses of aspirin for life to keep the pathophysiology in control. And if you have successfully desensitized that patient, that AERD is over. Those patients will not have massive eosinophilia, leukotriene, this, that, to give sinus disease again and again, and they will not require any surgery. They will not require even steroid therapy for long. They will not even require long-term topical steroid douching as well. Otherwise, if you have missed this aspirin sensitivity disease, you operate upon those patients 100 times, is bound to come back again. In my practice, I have operated upon patients who have been operated 20 times before here and there, and the aspirin sensitivity was not diagnosed. Unfortunately, those poor patients we have operated, and after desensitization, they no longer require any surgery in life. So how important is understanding the disease?
Thank you, Dr. Satish, for explaining in detail. Now we have another set of moderators, and we will discuss the CT, and it's always a pleasure to watch you, and really it's a great learning. Thanks a lot, and we will ready for the next session. We will be watching you continuously.
Thank you,
Sir,
sir.
one
Always
permission, sir.
Thank you,
pleasure
Doctor.
interacting with you.
Sir, one permission,
so
sir.
much.
How long do we give
Thank you.
anti-allergic fexofenadine in these patients, sir?
What?
We recommend
Dr.
anti-allergic
Jain, please continue your
fexofenadine or
discussion.
something like that.
Anti-allergic? What?
Systemic anti-allergic fexofenadine and all. is
Meanwhile, I'll
required.
request Dr. Rajbala Badoria to
No role.
felicitate the
Sinusitis has
chairpersons.
sinusitis,
Dr.
there is
SP
no
Dubey.
role of anti-allergic.
Please come over.
Thank you, sir.
Dr. Anupchya, please. Thank you, Dr. SP.
Hello.
Hello.
मेरा फोन लाना हो तो किधर गया? मेरा फोन किधर है?
Dr. Anupriya Shah. Thank you, Dr. Baduria. Now our next set of chairpersons will be Dr. Vikas Gupta and Dr. Smita Soni. Dr. Smita Soni, please.
कौन से दिखाएंगे, कौन से खिंचवाएंगे,
हम्म,
कौन से आप अब दिखाएंगे?
ये वो पहले नेक्स्ट ये पहला ये और दूसरा ये, बाकी खिंचवा दो। जब मैं ले लूँ ना तो ये टेटवा को चालू करा देता। सिंपैनिका में। हेलो हेलो सिंपैनिका में सब टोटल पेट्रोल लगती हो। हेलो हेलो
He enjoys that and he does it very nicely.
Hello?
हेलो
Hello?
हेलो हेलो
Hello,
हेलो
Dr. Jain?
यस एम आई ऑडिबल सर?
Yes, sir. Vikas here, sir.
हाय डियर, हाउ आर यू?
बस सर बढ़िया, all well.
Good
एमपीएन
morning, sir. Good morning, sir. Dr. Smita Soni here,
गुड मॉर्निंग।
organizing chairman.
So we can start, I think.
So our next case, as I mentioned, we'll go to variety of cases. After this, we'll have some complex draft cases to complete this endoscopic, sinus surgery science. So this case, are you getting something on the scan? Something on the screen, are you getting?
Yes, sir. Yes, sir. We can very well see.
Okay. So this disease, sinus disease, I told you, has variety of endotypes, and every endotype has a different underlying pathophysiological process. This classic disease of allergic fungal rhinosinusitis has to be understood differently. Here the underlying pathophysiology is patient is allergic to fungal antigen. And because of the antigen antibody reaction, because of the body's response to the allergen, this kind of a picture is developed. So this is mostly unilateral disease, mostly in younger patient, can be bilateral in elderly as well, but most often who are more immunocompetent. The reason being, it is the immune response of the body which is responsible for this, this kind of a disease. So what happens? What we inhale normally, in the environment, the fungus is ubiquitous. We inhale fungus every day during inhalation, and whatever fungus we inhale is taken by the mucociliary activity in the nose, is driven in the nasopharynx behind and then to the gut and out. This is how our body deals with fungal antigens. Now, those who are allergic to fungal antigen, and when the fungus enters the nasal cavity and happens to get trapped in the nasal cavity, the human body's reaction starts, eosinophilic activity starts, and then gives this classical picture of allergic fungal rhinosinusitis. His fungus happens to get trapped in the middle meatus, then into the maxillary sinus. The eosinophilic activity will come, the eosinophil come around and secrete a lot of immunoglobulin E, and the massive allergic reaction starts, and the sinus ventilation drainage is blocked, and this kind of, the vicious cycle starts. And this is classically diagnosed by Bent and Kuhn's criteria. We all know what Bent and Kuhn laid down in their criteria, that this disease gives certain classical picture of on radiology. What you see, can you see something on radiology classically?
Yes, sir. Yes, sir.
Yes, heterogeneous densities within the paranasal sinuses. Sinuses are expanding, and because of the expansion, you can see bone erosion all around, yet not invading the mucosa. This is pure antigen antibody reaction. That is the kind of endotype it is. That's why I purposely kept it, because it has a different dedicated treatment. So what you see is this heterogeneous densities is because of the fungus in the core and the degraded eosinophils all around. This is what gives the classical picture of this, chocolate butter sauce. What we remove is a very, very sticky solution. We claim it like chocolate butter sauce, and the core of this sauce is the fungus, and all around is the degraded eosinophils. And that gives a classical picture of this kind of heterogeneous densities wherever this fungal is trapped, this fungal antigen is trapped. So here, fungus acts as an antigen, and the body's immune response, spearheaded by eosinophils as a immunity reaction. So both these together give this kind of a picture. So this is non-invasive because this doesn't invade the mucosa, and it gives problem because it blocks the sinuses, ventilation, drainage, and keep expanding, and can give pressure problem, pressure symptom. Many a time patient come with a proptosis because of the pressure erosion. The orbital plate is dehiscent. This lamina can get dehiscent and can give rise to proptosis because of the pressure. Many a time patient with this disease in the sphenoid sinus, we have got many a time such patient presented with blindness because of the pressure on the dehiscent optic nerve, and because of ongoing adjacent inflammation in the optic nerve, they can present even with the blindness. Otherwise, it is silent problem. Patient can come with the same symptomatology of any sinusitis, nasal blockage, polyposis, discharge, all that. But specifically, they come with the pressure symptoms. So this is how this disease is. This is pure non-invasive, pure antigen antibody reaction. So why I'm emphasizing again and again is a different endotype, antigen antibody reaction. So in order to cure such patients, as far as the treatment planning is concerned, first part is removal of the antigen. This fungal antigen is the source of problem. So the role of surgery is to remove the antigen from everywhere. Wherever the fungus is trapped and multiplying, along with the eosinophilic material which has blocked the sinuses, you have to remove it. So surgery has a big role in terms of removal of all this material, everything acting as an antigen. And at the same time, establish the ventilation and drainage of the sinuses. And at the same time, because this is antigen antibody reaction, steroid is the mainstay of treatment, not antifungals. You have to make wide openings for future surveillance and for the steroid introduction, topical steroid introduction into the sinuses, because this is antigen antibody reaction and only treatment for that is the steroid. So you have to introduce more and more topical steroid in the paranasal sinuses to prevent future antigen antibody reaction. So the goal of surgery is to remove this antigen thoroughly. You have to remove each and every bit of fungus, otherwise it will again initiate the same problem. You have to widen the sinuses so their health is established by means of the mucosa will recover back by means of establishing the ventilation and drainage, and you give wide openings for the steroids to introduce inside. So this is the goal of surgery. So first part of the treatment is removal of the antigen. That is possible only by sinus surgery. So in this situation, once you diagnose AFRS, this is a direct surgical indication. During previous case, somebody asked about the maximal medical treatment. In such disease, there is no need of maximal medical treatment. This is an indication of direct FES. Direct FES, no need of maximal medical treatment. Yes, before surgery, you need preparation by means of giving steroid to reduce the inflammation. That's a different thing. But there is no role of pre-operative maximal medical treatment, as it is a pure surgical entity, in contrast to the previous case. Number two, since this is antigen antibody reaction in the post-operative period as well, you have to treat this antigen by means of preventing allergic reaction. This will require the allergic testing and immunotherapy as well. Number two, there is big no to any antifungals. This is a myth that these patients will require antifungal, being the fungal disease. Here, fungus is not invaded. Fungus is causing allergy. And for allergy, the treatment of choice is steroid. So these patients requires in the post-op period for some time even oral steroid to contain the inflammation allergy, and then long-term or even lifelong topical steroid therapy to contain the antigen antibody reaction. Big no, this is a myth. Big no to the antifungals at all. No research has proven any role of antifungal. And we have been treating for decades such patient without the use of antifungal in any patient. Though antifungals are reserved in certain situations, if you ask me. Number one, in pre-operative situation, to reduce the inflammation, you can, along with the steroid, you can add antifungal to buy the time. Sometimes the patient comes with a blindness. So until surgery, you can reduce the inflammation by giving high dose antifungal and steroid to, allow the, pressure, blindness or any other symptom to recover. Post-operatively, in highly allergic patient, you cannot give oral steroid. In that situation, to contain the allergy, inflammation to some extent, you can, like diabetic patients and all that, where you cannot give oral steroid, you can add on, antifungal for some time. But by and large, antifungals have no role. The role of surgery is to do classically. This is a classical indication for full house FES. Whatsoever limited or whatsoever diseases, this requires a full house FES, because you need long-term surveillance and long-term steroid introduction into the sinuses, steroid irrigation. So in contrast to the other, entities of CRS, other endotypes, this is a different one where you need a full house FES and post-operative allergic treatment, immunotherapy, and long-term steroid therapy. This is what this endotype needs. And what we see, we have discussed the CT scan in detail in the previous case. Yes, I'll touch upon only the positive findings. Number one, see this is a classical unilateral disease. Can you see?
Yes, sir. Yes, sir.
So there is no point in touching to the opposite side. A lot of people have raised question, why not to operate opposite side in advance to prevent future problems? Once you are treating the antigen antibody reaction, you are already treating in advance the disease to come back even on the opposite side. So there is no point in treating on a preemptive basis, on a preventive basis to the opposite side. So you have to stick to the unilateral disease, number one. Number two, as far as the anatomy is concerned, if I come from anterior to posterior, there's one positive finding which I will show you. Can you see this frontal cell?
Yes, sir.
See, This is the level of the beak. See this beak? See the beak? And this frontal cell is rising above the beak. Can you see? See or not?
Hello. Yes, sir.
This cell is rising above the beak. So this is what? Type 3 frontal cell. And what does type 3 frontal cell do? This narrows the frontal sinus outflow from lateral side. Can you see this? This
sir.
frontal sinus outflow, this entire outflow from here to here is narrowed by this big cell, and outflow is reduced to very narrow space for the frontal to drain. Can you see?
Yes, sir.
And this is a very, very anterior anatomy. See this anteriorly where the beak is and this cell is. So this is very anterior anatomy. So treatment of this cell is go behind this and fracture it out. I will show that. So in this case, I will show you how to deal with a type 3 frontal cell. What my point?
Yes,
Our
sir.
frontal technique to open the frontal sinus will remain same like I had shown earlier in the previous case. Okay? So we will go fast and focus on the removal of the type 3 cell, how to remove that. And it is very, very simple. You just go behind that cell and fracture it anteriorly. Number 2, see the concha bullosa. Can you see the pneumatized turbinate?
Yes, sir.
An inflammatory process inside the turbinate as well.
Yes,
So
sir.
this will require the treatment of the concha as well, definitely as the inflammation is extended into it. Can you see very clear? So
Yes,
this
sir.
is another additional treatment this patient will require. Rest is all like any regular sinus surgery. This will be a ipsilateral right side full house fess. Okay.
Okay, sir.
Next two
Sir,
cases are advanced ones. Yes, yes, please.
Sir, I want to ask one question. If the patient start orbital symptom diminution of vision, so what is the time to operate? Immediately, or you will give some medical management, then you operate?
You have to operate as early as possible. Meantime, you have to give medical treatment.
Okay, sir.
Until patient comes to the table, you have to give medical treatment to maximally reduce the inflammation. The goal is to reduce the inflammation. What my point?
Okay, sir.
That is very, very important. Any other question regarding AFRS? This is a very important entity, very common. Young children are most often affected, and there has to be a proper dedicated plan to treat this disease.
So what about septoplasty in this case? It's got quite a marked DNS.
But see, the opposite side knows airway is not blocked. And I will not, in this particular case, he has no complaint of blockage on the left side. Adequate airway. At the same time, I will not violate the opposite mucosa unnecessarily with the instruments. The patient has already fungal disease on this side. So will not do. Yes, in case it is required, you can do a limited septoplasty. If you want, I can show you.
Sir, have you observed?
What?
Hello?
Yes.
Sir, have you observed this allergic fungal behaving like an invasive fungal in some patient?
Invasive?
This allergic fungal sinusitis behaving like an invasive fungal sinusitis?
No. Allergic fungal and invasive fungal are two different entities. I mentioned during discussion, during previous case, invasive fungus means invasion into the underlying mucosa. You have to be very clear about it. Invasive fungus means invasion, and this is non-invasive. The underlying mucosa is absolutely normal. There is no invasion of the mucosa at all. So we have to be very clear in this. This is not invasive. Invasive fungus means no role of surgery. Only pure medical treatment for that voriconazole is the #1 choice. Lethal to aspergillosis. So we can continue. Ready? We can continue our discussion intraoperatively as well. So
Sure,
we
sir.
have already discussed the steps of sinus surgery during previous case. So now to save time, I'll go quick and focus only on those areas which were not discussed in detail. Okay?
Okay, sir.
Next case will be a draft 2. So I'll be back with the endoscopic picture in a couple of minutes. कैमरा तो इधर ही है ना इसका वॉल्यूम करना हेलो
Hello? Yes, sir.
yes madam so soon we are starting this case this will be right side full house face कौन तो बोलता है तो वैसे भी चालू करा hello
Hello. Yes, sir.
this is the primary unprepared picture of the right side nose can you see
Yes, sir.
multiple polyp and this mucin this classical fungal mucin and this is allergic as well this patient has severe allergy as well see this is the primary decongestion like we did in the previous case. So I am doing the same thing which we discussed in the last case.
Yes, sir.
This fungal mucin has to be thoroughly cleared. वो लगा देना वो divider वाला. So this is just topical application. Same solution, young patient, and I am using 1:1. If you use topical for 10 seconds or you use topical for 10 minutes, the effect is going to be same. So there's no point in keeping for long. Just apply on the mucosa. See the fungal mucus. See how the nasal cavity has opened up.
Yes, sir.
Even after the single application, it has opened up. See landmark. This is your turbinate, which is we know is a concha.
Yes,
These
sir.
are all multiple polyps.
Yes, sir.
See this concha. And this uncinate, which is see this how it is become
Edematous.
distorted. See this? Because
sir.
of it is ballooning because of the polyps coming from inside. So the single application of this saline adrenaline has, opened up the airway. No need to inject. Right. So, wash करते रहना सर. Suction भी रख. Luminal clearance. See this?
Yes, sir.
Multiple.
Sir, can you tell us the setting of your debrider?
At 5,000 RPM.
Okay.
See the multiple polyps. This is your concha bullosa. Massive polyposis. And see this uncinate is how distorted. We are not able to see the middle meatus at all because of this, which now I've opened this concha as well. See the concha?
Yes, sir.
The pneumatization within the turbinate. This was the cell within the turbinate. See this?
Yes, sir. Yes, sir.
And the mucosa was boggy. So everything distorted. You have to open up the anatomy under vision. You will find such complexities in every case, some or other way. In concha bullosa, in order to open up the middle meatus, in extreme concha situation, you may have to do a partial resection of the turbinate, or even sometimes the lateral plate removal is sufficient. See, I have removed the lateral plate of the turbinate. This is your uncinate process here. This is the polypoidal mucosa, and behind is this is your bulla ethmodalis here. This is your uncinate process here.
Yes,
In
sir.
between, this is hiatus seminaris. So I've got some anatomy after, see this, opened up the anatomy. Did nothing but just remove this polypoidal mucosa to open up this anatomy. This is a surgery of landmarks. At every point, you have to identify the landmarks to go further. And keep applying the adrenaline. Topical. See this? Reverse bite. See now, much better space.
Yes, sir.
Back. Wash. Now we have the uncinate in view. We have see, this is the uncinate process. See this?
Yes, sir. Yes, sir.
I am using the reverse biting. Turn it little below. Bite through the uncinate. Bite through it. Keep coming anteriorly until you reach the hard bone. This is biting through the uncinate to open the infundibulum here. This is the lower part of the uncinate process which I have fractured. See this?
Yes, sir.
And this is the maxillary sinus now I have opened. All boggy mucosa. See, this is the lower part of the uncinate plate. Now comes the role of red 40. Now, once I have removed this part of the uncinate, see this, see, this is all mucin. See the fungal disease inside.
Very clearly seen, sir. Inside.
So, this all boggy mucosa is expected. Though this mucosa is, see this, the turbinate branch. Sometime you come across while removal of the uncinate. I am using the cobbletter to cobblate that immediately. See inflammation, level of inflammation. Section. So what I have done initially, this is your maxillary sinus. See this?
Yes, sir.
And this is all the fungal disease within. Keep widening the sinus. So see the initial picture. This is our middle meatal antrostomy. Since this patient requires, such patient requires long-term irrigation, high-dose steroid irrigation, we are biased towards doing a mega middle meatal antrostomy. Mega antrostomy is everywhere. So that we can follow those sinuses with endoscopy better and we can introduce freely more and more topical steroid. There is mega middle meatal antrostomy. In mega, you can remove this medial wall right up to the posterior wall. See this?
Yes. Yes, sir.
Like, so we have done this middle meatal antrostomy. You can see very clear now. Can you?
Yes, sir.
Let's keep for a while. I can see the fungal material which I have not removed yet. We will. I told you this fungus acts as an antigen. And this has to be thoroughly removed. You have to make every effort to remove the fungal antigen. And what we use in such cases is hydrodebrider. I will show you. That is a pressure water jet that works 360-degree all around to remove the fungus from everywhere. So I have not removed the fungus from the maxillary sinus yet. I have packed the sinus mucosa for a while. Is the picture clear there?
Yes, sir.
Now, can you see the upper part of the uncinate? Meantime.
Yes, sir.
So meantime, I have packed the maxillary sinus with the Mucosal. This is the upper part of the uncinate. See this?
Yes.
This is a very important anatomy, as immediately lateral to it lies the lamina papracia. See this? I have fractured it. First, dismantle it, fracture it from its attachment. See this? The uncinate plate. Uncinate plate. See the polyps. And open up the middle meatus thoroughly. See my lateral limit. Here comes the lamina papracia.
Yes, sir.
So I have dismantled the uncinate, fractured it. See this? And since I am coming from posterior to anterior, so it is very, very safe. See the entire uncinate plate coming. See this?
Yes.
And acquired more and more space to work in the middle meatus. This is a strategy once you have narrow spaces to open up the space. See this?
Yes, sir.
What we achieved here, this is the lamina papracia, this one, this is lamina papracia. And since in the further work, I need this landmark to define my lateral limit. This is lamina papracia, okay?
Yes, sir.
This is your axilla. If you remember what I told you in the beginning, this is your middle turbinate. This is axilla. You need to open up till you reach the hard bone of beak.
Yes.
Open up the axilla. This is key. This will automatically take you to the beak. See, there is a very, very zone where I am working. By means of opening the axilla, it opens the book. Now, a child's play. Once you have done this exposure, you have seen in the previous case. Can you see now? I hope you are well versed with axilla. Anybody
Yes.
can reach to the axilla. See what I have done so far. The same strategy. Same strategy means you have full respect. Nothing to your lamina. This open. Feel there. Okay. Clear? Am I audible, sir?
Sir, your voice is breaking in between, sir.
Audio. Can you? Hello.
Hello. Right. Yes, sir. Now you're audible.
Audible, no? See, I have opened the axilla. I have not cleared the maxillary sinus yet. Okay? And
Yes, sir.
I peg this marrow cell towards the axilla. Now, using the 70 degree, I will clean the maxillary sinus. Hope the picture is good there.
Beautiful, sir.
So far, I have done everything with the 0 degree. Why I have opened the axilla first without clearing the maxillary sinus here? Because I need to work in the maxilla with the 70 degree and I need to work at the axilla with the 70 degree. So now I will work at both places without repeatedly changing the endoscope with the 70 degree. 70.
Sir, post-operatively, how frequently you call the patient for cleaning and suctioning of this face cavity?
Depending. The initial post-op visit, that is for sure, is after 7 to 10 days. See now, I am in the maxillary sinus. Then we call roughly after a month. 4 to 6 weeks or 8 weeks are the initial period for healing. See this fungal mucin.
Yes, sir.
मोटा देख सकते हो proud मोटा. See, you have to flush it. You have to use a high power suction, or you have to use a hydro debrider. I will show. These are the various strategies. This is our high power suction. 1 HP.
So what is your experience with the endochameleon, which they gives you the liberty to change the angulation without changing the scope?
Yes, that has been. I have tried once or twice, but that is cumbersome. Number one,
Yes.
cost is a limiting factor. If the if that is damaged, the entire thing is damaged in one go.
Yes.
So, see, we need to change our angle once or twice in this technique. See the beauty of the high power suction. We always advocate high power suction in sinus surgery. See how effectively the fungal mucin being cleared with the suction only. Could you see? It is otherwise a very, very sticky, cheesy material and difficult to remove so easily. Wash that. Second way is to flush it. Flush it, loosen it. Flush it to get it easily out. Divider. See this? Much better?
Yes,
Now,
sir.
I will remove this boggy mucosa. In the folds of mucosa, the fungus is hidden. See this?
Sir, are you using angle divider for this?
Yeah, 60.
Okay, sir.
70-degree endoscope, 60-degree divider. See how much of the fungus is still there? But mucosa is little boggy but not invaded. You can see. That is the classical of non-invasive fungus. With 70-degree, I can see I am working right on the anterior wall. That's the beauty of 70-degree. See this?
Yes, sir.
So cheesy material. This is high power suction. See this? Laga, wash kar. Naresh Manu. See this? Flush. Flush and flush and flush. Flush, high power suction, flush. This fungus has to be thoroughly cleared. If it is not cleared by this, we will use our hydro divider. Much better now?
Much better, sir.
Give me hydrodebrider. Now, what is hydrodebrider? It is a water jet. 360-degree high pressure water jet. Let me show you. It's again for Medtronic. So this is the nozzle of the hydrodebrider. This is the nozzle. See this?
Yes, sir. Yes, sir.
And I can rotate it 360-degree. 360 means 360-degree exactly.
Okay.
Like this 360-degree completely. And then flush it. So what I will do here, rotate, rotate, rotate. And this is high pressure. लगा सेक्शन लगाना है आपसे वो पीछे रह जाता है सेक्शन yeah now see
How much does it cost, sir?
I don't know we
360 degree?
yeah we bought long back I don't remember hata I will show you the pressure of the jet. This is a high pressure and you can rinse each and every corner of the sinus. It is very useful in frontal sinus. See, this lodges.
Beautiful, sir.
Now the next would be Mucosal. I will mop with the Mucosal. This will serve two purposes. One is to mop the fungal disease or any fungal particle on the surface. At the same time, it decongest the mucosa. So whatever fungal material which is trapped between the folds of the mucosa, edematous mucosa, can be mopped out. So this is a very important tool. Between the edematous mucosal folds, one can leave the fungal material trapped. See, this decongests the mucosa and flattens the folds. See the fungus?
Yes, sir.
So this is Mucosal mop. See, so many tools are required to clean CG materials. If you are still not sure, you can come by anteriorly to the canal fossa using your microdebrider. Now it is coming out. So it is very important to clean the maxillary sinus or anterior part. See the maxillary sinus, it always poses challenge. So I'm uncovering this entire anterior recess. Debrider. So much of boggy mucosa. See the boggy mucosa and the trapped fungal particles. On the slightest of the doubt, what can come from the canine fossa? That gives you 360-degree liberty to clean the maxillary sinus. मेरे को दे पानी. See, much better access.
Yes, sir.
Now flush. Flush, flush, flush. See the fungus.
Yes, sir. It is there in every nooks and corner.
Yeah. So you have to dislodge it, widen the exposure. Now. Now it is coming as a whole. See this?
Yes, 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 sir.
High power section has pulled out everything.
Great.
Now it is out. And give me hydrodebrider. See, it is clear
Yes, sir.
because it came one piece from the depth.
Yes, sir. Yes, sir.
So it
Sir,
gives
in
you a,
follow-up with,
that's why such patients require long-term follow-up, wide sinusotomies. Section laga. And see last my wash through the hydrodebrider. It is turning, turning, turning. And now this is jet. High pressure jet.
sir, in follow-up visit also you use this high pressure jet and this powerful suction?
No, no, no. That cannot be done.
Okay.
Nothing, nothing. Now it is pretty clear.
Very well, very clear, sir.
Aerosol. So this is frustrating, I would say. If we still and this not come out, I would do the come from the canine fossa with my other instrument. So the goal is to remove it thoroughly. This is antigen. That's why this is a different endotype. You need to understand again and again. This fungus is acting as an antigen.
Yes, sir. Very diligently you have removed every piece of fungus, sir. Very beautiful.
Now mopping with the marrow. Mopping, mopping, mopping. Wash. See now, the maxillary sinus
Yes, sir.
here with no fungal material, we have ensured by all means. And then now we'll focus on the
Frontal.
frontal sinus. See the above? That's
Yes,
the
sir.
maxillary sinus. Again, you can see everywhere.
Sir.
Pretty
Looks
clear.
like we are inside the maxillary sinus.
Yes. Okay. Yes. Now give me a Merocell. Leave us piece of Merocell in the maxillary. Meantime, we work in the front. Now this is towards the frontal, and we have a T3 cell here. We had concha, we have already removed the lateral plate. If remains floppy, we will do a partial resection. That is the concha. Now coming to the frontal sinus and type 3 cell. Number one, those who saw the frontal sinus in the first case, same philosophy. Easiest way to the frontal sinus. We've probably already done here. Let me show you. Easiest way. See, this is the region. What I want to show here, Merocell, chota. Anatomy first.
Yes, sir.
The medial limit, turbinate. We know. The lateral limit, lamina. We know. This is the medial limit, turbinate.
Yes,
That the
sir.
lateral limit, lamina.
Uh,
And this angle limit is the beak. And that will follow into the frontal, okay? In the same way.
yes, sir.
This is the beak. First,
Yes, sir.
let me define the beak thoroughly for you. Because this is the thickest bone. Now here, this is the beak.
Yes, sir.
Underneath the axilla, you can be pretty sure this is the thick bone. See this beak.
Yes, sir. Yes, sir.
Now this is the type 3 cell we know. So type 3 laterally placed, you know.
Mm. Yes, sir.
And that underneath the beak, this space is narrow cell. See this? Underneath the beak, there cannot be anything but frontal sinus. See this?
Yes, yes, sir. Yes, sir. Very well seen.
Simplest way. See anatomy. Here is your turbinate. This is your lamina. This is your beak. You have seen underneath the axilla. And where this beak ends is the frontal. But what is difference in this patient? What you open is a type 3 cell. Because this area is narrowed by what?
This type 3 cell is
See, this
compromising
is to
drainage.
show. What you opened is, so what you can do now, go medial to it. See this. I am going medial to it and elevate this. Give me more than that. Wow. See this. I had shown you on CT scan, go medial to it. See this. I am going medial to it. Can you see the cell?
Yes, sir. Yes, sir. She's opening up.
See now, just a minute. Can you see the cell and the sinus differently? Again, why I mentioned type 3 cell? See this. This is the type 3. And the sinus is medial. See this.
Yes, sir. Yes, sir.
Everybody remember what I said. This frontal recess is narrow cell laterally. So we went below the beak And what we opened laterally was the type 3 cells. So we went medial to it. I told you this is type 3 cell, so we went medial to it. See this medial space?
Yes, sir.
Very clear?
Yes,
Now
sir.
I
Yes.
told you the strategy. Give me a marrow cell to show very, very clear. Go behind this cell and fracture it out. I told you. We'll show you. Go behind this cell and fracture it out, then the entire sinus will be in front of you. So this type 3 cell was a challenge. What it was doing? Blocking the sinus drainage pathway. Let me show you in a minute. Remember, concentrate what I'm showing. Type 3 cell and frontal sinus and how to deal with that. See underneath the beak?
Yes, sir.
This lateral space, which has compromised the frontal sinus, is what? Type 3 cell. Okay?
Yes, sir.
Since it has compromised the frontal sinus, so you have to go medial to it. Can you see this space medial to it?
Yes, sir.
This space medial to it. See this?
Yes, sir.
I am going behind and fracturing this cell out. See, I am going behind this cell
Yes, sir.
and fracturing this cell out. This is your frontal sinus. See, frontal sinus is behind.
Very clearly seen, sir.
See, the frontal is behind. What you see there is anterior is that cell. Let me show you how to remove this cell completely to give a wide opening of the frontal sinus. See this? This is the beak which is overhanging.
Yes,
See this?
sir. Yes, sir.
Underneath the beak, laterally this cell. Look here, pani mati kar chalo to. Laterally is this cell. This is the cell laterally. And I fracture this cell and medially behind that is sinus.
Yes, sir.
Got my point or not? This is sinus behind. And in order to widen the sinus opening, you need to get this cell completely out.
Yes, sir.
So this is the sinus and this is the cell here.
Yes, sir.
So I need to get this septation out. See this septation which I am mobilizing?
Yes, sir. Yes, sir.
This is cell. This is cell. So I have to get that cell out. Okay?
Yes, sir.
Accurate.
Sir, they say that frontal sinus is very difficult to treat and there is a recurrences are very common. So what are the factors which can be done to prevent
You
recurrence?
have to open the sinus. Sometimes the surgeons are mistaken by means of opening the cell, considering it as a sinus. I told you laterally what I opened was a cell. See this cell.
Yes, sir.
And we know from CT scan this is type 3 cell and the sinus is medial to it. So we went medial and this is the cell. See this?
Yes, sir. Yes, sir.
So now I am getting this cell out. Go behind and fracture it anteriorly. See this? I am fracturing it anteriorly. And now see what you have opened is 120. What you have opened is
Sinus.
sinus. Give me a marrow cell for a while to show you better. Ask everybody in the audience whether they understood or not this type 3 cell and the sinus relationship. The cell compromise attached to the anterior wall compromised the sinus drainage and pushed it medially. So what is lateral in this entire space is this cell. And what is behind and medially is the sinus. Got my point?
Yes, sir. Yes, sir.
I fractured this cell and now widen the sinus thoroughly.
You have widened the sinus outflow tract.
Yeah,
now.
this is the cell wall. See this?
Yes, sir.
And the sinus is behind, occupying this fungus. See this?
Yes, sir.
See the sinus behind. The sinus is behind us. See this cell laterally and anteriorly. I need to get this out. See this cell. I want to get this cell out. See this?
Yes, sir.
More you widen the cell, more your frontal sinus opening is clear. We see from CT scan. See this cell, which is attached laterally,
Yes, sir.
getting this entire cell out.
Sir, how can you prevent restenosis of this frontal recess, sinus outflow tract?
Yeah, so widen it to the limits. Widen it to the limits means and medially till turbinate, laterally till lamina.
Huh?
Don't leave the septation. Now I'll show you one more interesting thing. See, this is the sinus.
Yes, sir.
This cell is left this much only. See, I have removed most of the cell.
Yes, sir.
Wash. And sinus was containing the fungus. Cell was anterior, sinus was behind. Could you see? Now I am washing into the sinus to get this fungus out. See, this fungus came out.
Yes, sir.
I am flushing the sinus. Fungus is out. See the
Yes,
beautiful frontal sinus.
Yes, sir.
That is sinus. And see, still the cell remnants are there.
Yes, sir. Yes, sir.
Remnants. But we have adequately opened the sinus, so I will do something more. Now, one more interesting finding in this articulated law. See this beak, can you see?
Yes, sir.
This is over projecting and narrowing the frontal from anteriorly.
Yes, sir.
The original beak is a very, very thick structure, but this is the beak projection. So what I will do further, I will use my articulated punch. This is Karl Stohr's articulated punch. And bite through this beak. See this beak?
Yes, sir.
And I can tackle this over projection easily. So this will further widen my frontal sinus. See this now?
Yes, sir.
So see the projecting beak has gone, and that beautiful instrument is a amazing instrument is articulated punch. See now,
Yes, sir. Very well seen, sir.
the projection has gone. Now, it is the still remnant of the cell is there. Okay. Now, let me define my skull base behind this reverse. I had shown you the anterior limit of my opening is the beak. We have reached. Can you see?
Yes, sir. Yes,
Lateral
sir.
limit is lamina. We have already reached.
Yeah.
Medial limit is turbinate. We are already on it. Posteriorly, I can widen a little bit to the level of the skull base.
Skull base.
And here I'll be using the rear facing adenoid blade. Make it front facing here with 70 degree. This will further widen my frontal sinus opening anteroposteriorly. See this?
Yes, sir.
Always use in the lumen, not forcing anywhere on the bone. See the frontal sinus now?
Yes, sir.
So this is further anterior posterior widening by this fantastic skull base blade. I call it a skull base blade because you can work under vision with a 70-degree at the skull base with this. Okay.
Okay, sir.
So, one question, when do you decide that you will use a drill to do this procedure? And now you're doing angulated instruments. So can we
Oh,
discuss that,
yeah.
sir?
Yes, yeah. That's what I'm coming to in the next case. Next case is a draft.
Sir, angulated instrument, what is the, like, how do you judge that this can be removed by instrument only, the anterior beak?
What thing?
So in
What-
this particular case, you have simply used an instrument to remove the beak.
So
That's what
type 3 cell, no, type 3 cell was the only culprit, you know,
Okay, okay.
and we
So
could see the height of the type 3 cell on CT scan. If you
Right.
remember, if you remember,
Yes,
we
you
saw
have
the height,
shown it, huh?
yeah, going just above the beak, which is reachable. See the cell here.
Yes.
So type
So
3 cell going just above the beak is reachable from below, you know. Had this
Okay.
been going more than 50% height of the frontal sinus above,
Okay.
there would be difficult to reach out the cell above.
Right. Sir, I saw you using the debrider in the posterior direction. So how will you prevent the skull base? Like it was almost a bit blind when we're expanding posteriorly.
No. It was not blind. I told you the principle behind the use of debrider to use
It
it
should be
on the
visible.
lumen, not
Okay.
on the surface, not forcing on the bone or anything.
Sir, what was
told
the
me.
posterior limit which was making you confident that I can go ahead here clearly?
Just until I reach the bone. See, you
Okay.
don't have to use any force on the bone.
Okay.
Debrider, the principle of debrider use is to use in the lumen and allow the tissue to get sucked into it. No forceful use. Allow the tissue to get sucked into it. Allow the tissue to
Okay.
fall into it.
Right.
Don't forcefully use on the surface. Try to understand. Repeatedly, I am saying the same thing. If you forcefully use on the bone, you can damage. So
Okay.
use in the lumen, the soft polyp will fall into it, automatically jump and fall into it. Debrider is for that only. See
Okay.
now the frontal is widened further.
Right.
Yes, sir.
Such a big frontal opening.
Yes, sir.
The size of the final frontal opening should be to the limits. And see this remaining septations of type 3 cells. Now much better seen?
Wonderful,
Yes,
sir.
sir.
Now give me. I will show you under vision. See this. See this remaining septations. Now I am working in the safe zone above. See the septations I am removing with the micro debrider. The डालना है कैमरा पे See now
Yes, sir.
your frontal sinus, that is the type 3 cell which was obliterating. Now your frontal is wide open in front of you. This is what the treatment of the type 3 cell. I hope you understood well. Type
Fantastic.
3 was type 3 cell was completely obliterating the frontal outflow almost. So I went medial to it, went behind it and fractured out and remnant we divided. See that?
Yes, sir.
You asked me how I use this debrider safely on the skull base. Again, see this? See this? Reverse blade. I am using in the lumen. I am not forcing on any surface. See, only the soft polypoidal tissue is getting into this. See this?
Yes, sir.
So it is pretty safe. It depends you use this tool, this is a very, very useful tool. Not forcing anywhere. Structure which is coming automatically, you have to take. Say the cell. See, your skull base is completely flushed. How big your frontal sinus opening is now? See this?
Yes, sir.
Everything crystal clear. See that? Give me a pack for a while. Don't
So
keep.
now,
Yeah.
so
Don't.
nowadays you do osteoplastic for any indication, anything?
Yes. See, the decision between a lot of dark osteoplastic or endoscopic and open approach is a very crucial decision. I tell you how to make the decisions. For audience, to address the frontal sinus, the surgical, exercise is advanced. There are variety of draft procedures available to remove the beak, and you can address well within the frontal sinus. In the last case, I will show you orbital transposition. Will transpose endoscopical orbit to go far laterally, So there are variety of techniques which have evolved to address the frontal sinus disease. Earlier, which was difficult to treat endoscopically, can now be treated endoscopically. But there are certain situations where endoscopy is behind the open approach, and we need to keep in mind those. So in frontal sinus disease, we have our own indications to define which to be treated endoscopic and which by open, which is known as osteoplastic flap. So advantage of endoscopic, number one, you establish the ventilation drainage and keep the sinus function intact. That's the biggest advantage,
Okay, sir.
In endoscopy, you can remove the floor, this beak, and go into the frontal sinus head on. And this has clearly expanded the indication. Indication matlab? The frontal sinus disease like the mucosal disease like we have been treating can be addressed. Non-mucosal disease tumors can be addressed by the endoscopy. Nowadays, variety of benign as well as malignant tumors being addressed endoscopically because of the advancement reverse in the surgical science. CSF leaks from the frontal sinus can be very well addressed from endoscopy. So that because of the advancement in the endoscopic technique, draft props, and so many other, reverse blade again. See, that was the septa which I dismantled.
Sir, when do you consider crenalization of frontal sinus, sir?
Not needed. Once you do the expanded approaches, don't need all this canalization and all that. So what I was telling, the indications are expanding. But your question I am now coming to, when to go by open approach in this era? There are three open approaches to the frontal sinus. One is osteoplastic, like you described. In that, you open the frontal sinus from above. You make a bicoronal incision, remove the anterior wall of the frontal sinus, remove the disease, then pack the frontal sinus outflow.
Yes, sir.
And obliterate the frontal sinus by means of fat, muscle, whatever,
Yes.
bone, whatever. That is osteoplastic flap and obliteration.
Yes, sir.
Process is cranialization of the frontal sinus. Means when frontal sinus is not treatable even after Lothrop's, even after obliteration, still the inflammation is coming. See the frontal sinus work now in this patient.
Yes, sir.
Complete flushing of the skull base. Can you see?
Yes, sir.
Frontal sinus per se, the type 3 cell was removed. This is the ethmoidal skull base. That is the ethmoidal skull base. Here is the site of तीसरा कैलनी क्या नाम है कैसे अंडर करा. See, this is the ethmoidal skull base. Can you see very clear?
Yes, sir.
Everything done. So the second open procedure for the frontal sinus is cranialization.
Yes,
When
sir.
everything fails, in obliteration procedure, osteoplastic flap, you have to remove each and every bit of the mucosa from the frontal sinus before obliterating. That's my point.
Yes, sir. Yes, sir.
Sometimes it is not possible, particularly when you have a deficient posterior wall over the dura, and you are not able to remove the mucosa completely. In that situation, or fractures of the posterior wall, even if your osteoplastic flap is failed, the next procedure is cranialization, open procedure. What do you do in that? Simply remove the posterior wall of the
Posterior
frontal
wall.
sinus completely. Remove open process, bicoronal incision, remove the posterior wall, and then allow the brain to expand to the anterior wall. So there is elimination of the frontal sinus. You obliterate the frontonasal the pathway from below and allow the dura to expand anteriorly. That is a final definite procedure for any massive frontal sinus disease which is recurring, not getting treated by any means, and the posterior wall is damaged. In that case, cranialization. The frontal sinus becomes a part of cranial cavity.
Cranial cavity.
Dura expands the frontal sinus and the frontal sinus anymore. The frontal sinus is eliminated. Once there is no frontal sinus, there is no frontal sinusitis. As simple as that.
Sir, how often have you done this and what is the long-term care?
Yeah, we
required?
have done couple of cases. This is final solution. No care after that. There is no frontal sinus. It becomes a part of the cranial cavity. The dura and brain expands to the anterior wall. That's it. That is cranialization. Now, sometimes the anterior wall is deficient, posterior wall is good, and anterior wall is a problem. In that case, we do the cranialization. That is Riedel's procedure. Riedel describes. In that situation, the anterior wall of the frontal sinus is completely removed. See, I am back with a 0 degree now. Can you see?
Yes, sir.
I am with 0 degree. My frontal is above. You can see the frontal sinus with 0 degree also.
Very well seen, sir.
This is the region of the anterioethmoidal artery. This one. That's the artery per se. This one. See this?
Yes, sir.
Exposed vessel. So I am back to 0 degree. And my ethmoidectomy, anterioethmoidectomy is due now. And what is left is this part of the bulla. See this?
Yes, sir.
So now this ethmoidectomy is completed. And see the fungus everywhere. You have to flush laterally with lamina. See the fungus within it. See the roof of the maxilla. What is there? So the third procedure was facialization I was describing. So in that you remove the anterior and obliterate the frontal sinus and reconstruct the anterior wall with the bone cement. Got my point?
Yes, sir.
So that is Radial's procedure of facialization. Now your question out there. When
do you-
to go for open procedure in this era?
Yes, sir.
See, what all you need in closed procedure, drainage procedure, that is Lothrops or draft. What you need is a wide drainage pathway. Where the open procedures are, the endoscopic procedures are effective, when you have a big frontal sinus, you have a big drainage pathway which doesn't stenose easily. Okay?
Okay,
And
sir.
that is where the success of the endoscopic procedures is. And where is the success of open procedure, where you need to remove the each and every bit of mucosa when the frontal sinus is not very big.
Okay, sir.
If there is a frontal sinus, huge scallops, hidden areas, remove the mucosa, you can leave the mucosa behind. You know?
Okay, sir.
And leaving mucosa behind, if you obliterate, it is going to fail. Got my point?
Yes, sir. Yes, sir.
Obliteration is much easier in smaller sinuses where you can easily remove the mucosa and obliterate. So our philosophy is, if patient has a recalcitrating frontal sinus disease, difficult frontal sinus disease, if the frontal sinus is too big, we are biased towards doing Lothrops, drainage pathway. Because in big sinuses, the drainage is unlikely to be stenosed. Okay?
Yes, sir.
But in big sinuses, the removal of the mucosa and obliteration is unlikely to be successful. You are likely to leave the mucosa behind. See the enterothmoidectomy.
Okay, sir.
So if you bad frontal sinus disease not getting treated by usual means, and the sinus is very small, what will you do? In a small sinus, if you do drainage, Lothrops or anything, it is likely to stenose again. Got my point?
Yes, sir.
In
Yes, sir.
small sinus, if you try to obliterate, it is much easier to remove the mucosa and obliterate. So by and large, if the sinus is very small, you are biased towards obliteration, osteoplastic flap.
Okay,
If the
sir.
sinus is very big, we are biased towards endoscopic. This is the basic criteria. So when it comes to the repeated disease or any disease in the frontal sinus, we look at the sinus dimension, mucosal status, and take a final call whether to be done open in this endoscopic era. So in very few percentage of cases, still there are indications for open surgeries. Now see, 0 degree, what we have done, anterior frontal sinus, the maxilla is below, can you see?
Yes, sir.
The last part is
Very good.
post-operative and sphenoid.
Sphenoid.
We have discussed in last case, before doing post-operative, we discover the landmark of
Sphenoid.
sphenoid ostium. See at the level of lower border of the orbit. Can you see this?
Yes, sir.
Roof of the maxilla. See this landmark.
Yes,
At
sir.
this level, medially we will go inside the post-operative. See this? Little widen it. Here I am not doing posterior technique. See this? Because I don't know how posterior I can go safely. Working medially into the turbinate to find another landmark. See this landmark? This is superior turbinate.
Turbinate.
This is superior turbinate. See this?
Yes, sir.
This is nasal septum medially. See this?
Yes, sir.
I will remove lower 1/3 of the superior turbinate. See this? Go see this, go flush along the septum.
Yes, sir.
See this line here. Not above that.
Yes,
And
sir.
see where I am? Sphenoid ostium. Can you see?
Yes, sir. Very well seen.
See, flush along the septum. That is the key. Now, having seen this level of the sphenoid sinus, anything anterior to it, I can remove it.
Right, sir.
That is why we discovered the sphenoid sinus. Got my point?
Yes, sir.
So this is my safety caution that while doing post-operative, I am not supposed to cross this limit of the sphenoid sinus behind. I hope it is clear.
Yes, sir. Sir, accidentally, if there is a CSF leak, it's very minor, some millimeter leak is there. Should you repair on the table only, or you should wait?
That is the best
For you to
opportunity
do
at the same time on the table. You can't leave the leaking, skull base. It may invite infection. You are already operating in an inflammatory infective field. So never think of leaving that behind. Now, that is my sphenoid sinus ostium. Can you see that?
Yes, sir.
Show me. Now what I am trying to show you is why I saw the sphenoid first. See, this is the sphenoid. See the sphenoid? Anything anterior to it, I can remove it without keeping in mind any damn thing. Lateral limited lamina, see this?
Yes, sir.
I can go out. See this? I am removing everything which is anterior to the sphenoid. This is all posterior cavity. Posterior cells. See the sphenoid?
Yes, sir.
You have to keep an eye on the sphenoid and work anterior to it without fear. No optic now, carotid can come anterior to it. Simple. See, all these cells I can remove faster without any fear. Lateral limit is lamina. See, all these cells anterior to it I have removed. See this?
Yes, sir.
This is how the posterior thyroidectomy is done in a safer manner. Because you have no fear of injuring anything as long as you stay anterior to sphenoid ostium. See the complete cavity of the posterior thyroid.
Yes, sir.
See the posterior thyroidectomy. It is like a box. Lateral limit is lamina, superiorly skull base, medially this turbinate and the septum. See the posterior thyroidectomy done?
Yes, sir.
And now finally this was our ostium. Removing this lower 1/3 of the.
Sir, your debridement is working like a brush on paint brush. Very smoothly, very nicely.
Now I'm widening the sphenoid. I'm used to. See, widening the sphenoid. Staying on the anterior wall. Never use debridement inside the sinus. Work only on the anterior wall. If you are used to, you can use the side punch, hamburger punch. There are many tools. I am used to. See the wide sphenoid sinus. The lateral limit is lamina. See this? And this is what the full house has done in this again. Watch that.
Sir, have you come across any case in which which is a very interesting thing which you found intraoperatively which was not there in CT scan, sir?
Which I didn't get your question, madam. Can you repeat?
Sir, have you found any interesting case in which, in spite of very good CT scan, some finding intraoperatively which you find which was not there in CT scan? Not in this patient, in any other patient.
Yeah. See, if you have not thoroughly seen the CT scan, such surprises are not uncommon. That's why I always mention read CT scan yourself, not to rely on radiologist's report. They cannot spend time on it. They have no time. So read CT scan yourself. This will clear all surprises. See the full house face cavity.
Yes, sir. Beautiful, sir.
So strategy in face is made according to the safety, the 40. Safety concern is very important. CT scan anatomical understanding is important. Developing landmarks is important. I would never do a post-operative without looking at the sphenoid sinus first. You have to make certain principles. Time is no criteria. You can do faster, much faster with landmarks in view, Much
Yes, sir.
faster doesn't mean that you are doing rash.
Sir, you look make you this your demo look like so easy because you are master, but when we do, we are stuck somewhere here and there.
So follow landmarks. This will not happen. We are all same. Just keep following the landmarks. It's just matter of gaining confidence by, knowing the landmarks. You have to have complete three-dimensional picture of the in your mind while operating in this area. If not, then the confidence level will be low. If confidence is low, then either you will end up with complication or do the incomplete job for the fear of injury. See this? This is the cavity. Full house
Excellent demo,
face
sir.
cavity can be visualized endoscopically in your outpatient department. You can see now your douche, whatever solution you recommend to the patient will go freely in all sinuses. With this, mucosal out maximum, so healing will be faster. And this is allergic disease. This is different from the previous patient. This will require more steroid. This require more thorough removal of the fungus. This requires more bigger openings. In AERD, had this case been AERD, I would do bilateral draft free, Lothrops completely to ensure solution reaching everywhere. I may have to do a medial maxillary bilaterally to ensure my solution reaches there, because that is the highest level of, on the spectrum of highest level of inflammation. So according to the underlying pathophysiology, you have to define your surgical strategy. Okay, so that's the final
Okay, sir.
picture. Thank you
Excellent
so much.
demonstration, sir.
So thank you so much for your attention, and we will move on to the next two cases quickly.
Yes, sir. Thank you, sir.
Now I request Dr. Kavita Sachdeva ma'am to please felicitate the chairperson.
कल की कैटवॉक बुला दे फटाफट अमन लगवा
For the next surgical demonstration, I would like to call upon Dr.
कितनी देर में
Saurabh
फ्री हो रहा है पूछ
Pachori
कैटू चौधरी को
and
लिया जल्दी 2 मिनट में आ रहा हूँ
Anil Kumar Jain, sir.
अपॉइंटमेंट ढाई से 6:30 है ना?
मैडम से बात करो
चारों तरफ से
हेलो हेलो
Hello. Good afternoon, sir. Yes, sir.
यस सर
Yes, sir. I am Dr. Anil Jain from Chairperson Medical College, Bhopal, sir.
सर
Hello.
यस सर आई
Sir,
कैन
I'm Dr. Pachori from Indore.
हेलो क्या हाल है
Hello, sir. Yeah, बढ़िया sir, बढ़िया.
नाइस टू हैव यू
Thank
So
you, sir.
this-
Thank you.
next case is a interesting situation. And next to this
Yes.
will be the highest level spectrum. After this, this patient is an operated patient. See this, what happens when you do an incomplete job.
Yes, sir.
This patient, the surgeon has done sinus surgery so well. See this, you can see the cavities.
Yes, sir.
This patient comes with a repeated severe headaches on the left side.
Okay.
Can you see the frontal sinus?
Yes, sir.
Endoscopically, when you see the upper part of the turbinate has blocked the frontal sinus axis.
Yes, sir.
So the operating surgeon is giving again and again antibiotic steroids and tried to open the frontal but could not. And
Yeah.
patient is facing problem again and again.
Yes, sir.
See, this is the level of the frontal recess and the frontal sinus.
Yes, sir.
And such patient requires one shot solution. See,
Yes.
ultimately what this frontal sinus needs is ventilation and drainage,
Yes, sir.
which is not happened because of inadequate work at the level of the frontal recess.
Yes, sir. True, sir.
I've always shown that widen to the maximum
Yeah.
and treat the turbinate adequately so that do not block the access.
Excess.
At the end of the surgery, you have to ensure there are topical reaches everywhere there.
True, sir.
If that doesn't happen, then it's a problem. And this is what happening in this case as well. So
Yes.
our goal is ready. So in this case, the goal is to make sure your frontal is wide open,
Yes, sir.
whatever inflammation is removed, and there should be a clear pathway
Yes.
for the ventilation and drainage. Your topical should reach freely flowing inside the frontal sinus.
Yes, sir.
And that will require a little, see this? In the sagittal plane.
Yes, sir.
That will require dealing with this beak.
Yes, sir.
We have to do something so that if I remove this beak,
Yes,
if I
sir.
remove this beak till here,
Yeah.
I'll have a 0-degree straight access into the frontal sinus.
Yes, sir.
And this patient, after such multiple procedures suffering, requires a final solution, and that is a draft on this side, draft 2.
Yes, sir.
So that's a final solution. See the frontal sinus there. Yeah. The frontal sinus there, here, and it is completely blocked. And see, this is the region. This beak is the region.
Yes, sir.
So this is a good example of a limited draft 2 on ipsilateral side.
Okay, sir.
For the beginners, this is the ideal case for the indications of the draft.
Yes,
The
sir.
next case is a major case. I'll show you how it is the disease is trapped in the lateral part of the frontal and going into the orbit, which requires orbital transposition.
Okay.
So that will be different, but this is a basic case for draft. So what all is required in this case is removal of this bone. See this?
Yes, sir.
This bone is the obstacle for ventilation and drainage of this sinus.
True, sir.
If I remove this bone thoroughly and this bone here, I will have a head-on access into the frontal with 0-degree.
Okay.
Now, the myths about the draft. This is not a complex procedure, not a lot. I would say this is the simpler than a regular sinus surgery.
Okay.
Secondly, this is not a dangerous procedure because you operate in the most, I would say, the safest zone in the paranasal sinuses.
Yes.
Away from the skull base, more anteriorly.
Hmm.
You have to drill this bone. Only thing in danger is the outside skin if you go outside the sinus.
Yes.
At the most, if you do buttonhole, put a suture. That's it.
Yes, sir.
You are miles away from the skull base. You operate here in this region. And what the challenge is the thick bone. You have to drill through the thick bone more and more and more and more. So thick bone is the challenge.
Yes, sir.
Got my point?
Yes, sir.
So that is the challenge in this disease.
Yes, sir.
Draft and its modification have revolutionized the frontal sinus surgery. And what I expect from any endoscopic surgeon must be well versed with the draft procedure.
Yes.
This simplest region, only thing it requires is a dedicated drilling. You should have a high-speed drill, which I'm going to show you. And next 10 to 15 minutes will be through.
Yes, sir.
Maximum 15 minutes will be required for this draft.
Yes, sir. So there
So
is a
draft-
request.
Yeah.
As we have lot of PGs, would you just tell us about all the draft procedures in short? Draft 1, draft 2.
Okay. So draft 1, you can say widening of the frontal sinus on the same side till frontal ostium, which I have shown in last 2 procedures.
Yes, sir.
Draft 2 is, you have seen the beak forming the floor.
Yes, sir.
So drilling of the beak and the anterior wall of the frontal sinus completely. So the frontal sinus is marsupialized in the nasal cavity directly.
Yes, sir.
If you do on ipsilateral side, it is draft 2.
Okay.
Sometimes the medial limit people keep till turbinate, it is draft 2A, till intersinus septum draft 2. That is divided for their convenience.
Yes, sir.
So by and large, the beak you have seen forming the floor and the anterior wall of the frontal sinus. This beak which forms the floor as well as anterior wall.
Yes, sir.
If I remove this, I can do entire frontal sinus work with 0-degree. This is draft 2.
Okay.
If you do this draft 2 on either side, both sides.
Yes, sir.
If you do this draft 2 on both sides, along with removal of the intersinus septum
Yes, sir.
and upper part of the nasal septum,
Yeah.
and it is draft 3 or modified Lothrops, endoscopic Lothrops.
Okay.
The same procedure. This is called marsupialization of the entire bilateral frontal sinus in the nasal cavity. There is no floor of the frontal sinus left. So frontal sinuses bilaterally drain into the nasal cavity
Yes.
directly. This same procedure was described by Lothrops more than 100 years ago from outside.
Okay.
Removal of the frontal sinus floor,
Yes.
which now we do endoscopically. This is called endoscopic Lothrops. Okay?
Yes.
So
Yes,
this is
sir.
draft 3 or modified endoscopic Lothrops.
Hmm.
Now,
Sir.
with the advancement in the surgical technique, there are many modifications to draft have been described and we have been doing in our clinical practice. For example, if I have a patient, let me show you. Yeah. If I have a patient with a disease in the frontal sinus ipsilateral and going far laterally here.
Yes.
That's my point. Far laterally, which even with the draft on the same side, I am not able to access.
Yes, sir.
What you can do a regular draft 2, do a septotomy, and come with the endoscope and instrument from the opposite side through the septotomy to access the far lateral area. That is modified hemilothrops.
Hemilothrop.
Got my point?
Yes, sir.
Clear?
Yeah.
If along with this, there is a minimal disease in the opposite frontal sinus,
Yes, sir.
with otherwise ethmoids and the frontal recess being normal on the opposite side. What you can do along with the draft and posterior septotomy, you remove the intersinus septum to allow the frontal sinus, opposite frontal sinus to drain from this side.
Yes.
That is modified subtotal Lothrops.
Subtotal.
Got my point?
Yes, sir.
Then if you have a situation when you have a tumor or a CSF leak in the frontal sinus, medially,
Yes.
and frontal recesses are normal.
Yes,
Frontal recesses drainage pathway is normal.
Yes.
What you can do, you can remove the central part of the beak without disturbing the frontal recess on either side.
Okay.
And remove the beak in the central part and the intersinus septum to go directly there to remove the tumor or CSF leak and come out.
Yes,
That is modified central Lothrops without disturbing either side of the frontal recess.
Frontal recess.
Then the last procedure is orbital transposition,
Yes.
which we have a next case, which let me show you why I am saying so. In that situation, if you have a disease which is going far laterally into the frontal sinus,
Yes,
see this. See this CT scan of the next patient. See this allergic fungal disease going far laterally in the frontal sinus.
Up to there.
And by eroding the floor going into the orbit there.
Orbit.
See? And this frontal recess is so narrow to communicate far laterally even into the orbit. You need a drainage also later on.
Yes, sir.
First of all, from a disease which is going into the orbit here, how can you remove endoscopically, number one, from here to here? Impossible.
Yes, sir.
Secondly, if somebody says, I can come with external incision from here, through the eyelid,
Yes,
and remove this lateral part of the disease and come out and remove this endoscopically, how will you give the ventilation and drainage from inside to this lateral part?
Yes, sir.
Impossible.
Impossible.
So this requires a dedicated procedure. What we do in that, with a draft on this side, we remove this floor of the frontal sinus, roof of the orbit, and the medial wall completely. This bone we remove completely and separate the periorbita, keeping intact, and push it laterally. So orbit is transposed laterally, and then you have a wide corridor. You have a, let me show you. You have a wide corridor from here to here, addressing like this.
Yes.
We will come from opposite side, remove this part of the medial wall and this part of the roof of the orbit, remove the bone and push the periorbita, and then give a wide drainage pathway. This is endoscopic orbital transposition. This is next case. So these are the various modifications of the draft. Lastly, one of the most important modification. If you have a case wherein you have done a sinus disease, frontal sinus disease on one side. Let me
Yes.
give the previous example. This is very important. Let me, the same case which we are operating now.
Yes,
See
sir.
this. We have a disease on this side, suppose,
Yeah.
which we are now going through the same side. Now,
Yes.
during previous surgery, had the surgeon damaged the orbital wall, lot of orbital fat prolapse happened during previous surgery, and
Yes.
given a complete scarring this region, and going through the same field is difficult now.
Yes, sir.
If you try to go in the same field, you are going to damage the eye further. Because
Yes.
you have done a lot of scarring and fibrosis because of the orbital damage, fat
True.
prolapse, and so on. In this situation, had this happened, I would not go to this case from this side.
Yes, sir.
I would not disturb this at all. I would go from the opposite side, normal side, absolute normal side, opposite side. See this.
Yes, sir.
I would go from the opposite side, do a draft 2 on the opposite side,
Yes, sir.
and do the intersinus septotomy.
Okay.
Got my point?
Yes, sir.
And allow this disease frontal sinus to drain through the normal sinus.
Okay, sir.
Because this disease frontal recess is difficult to enter again.
Enter again. Yes,
This
sir.
is called modified mini Lothrop's.
Mini.
How many variations you have heard?
Yes, sir.
So every variation has a different indications. So
Definitely.
in our armamentarium, which all endoscopic surgeons dealing with the frontal sinus should have all this in our armamentarium, along with all 3 open procedure: osteoplastic flap,
Yes, sir.
cranialization, and facialization.
Yes,
So this is all complete frontal sinus package.
sir. Yes, sir.
Sir, what is the age of the patient and when the patient was operated earlier, sir?
This one?
Yes, sir.
It was operated earlier also, na, sir?
Yeah. Twice.
Twice, sir.
Yes.
Okay, sir.
The problem is entering through that scarring for the surgeon is difficult. So now we will enter head on into the sinus directly.
Okay, sir.
And this is very, very simple procedure. I tell you, draft is all about drilling. That's it.
Yes.
I will show you what is the danger area, what is our limit, where we are not supposed to go.
Please, sir.
And that is behind. Posteriorly is the skull base. I told you from the level of the beak, the
Yes, sir.
skull base, the beginning of the skull base, beginning of the cribriform plate is 1 centimeter.
Yes.
Okay? So, in that situation, you have to define your posterior limit, that is beginning of the cribriform plate.
Okay, sir.
That is the beginning of the cribriform plate, that is first olfactory neuron.
Yes, sir.
That is your posterior limit. And stay anterior to it without any issue. There is no critical structure there.
Yes. Sir, in case of severe scarring or a fibrosis, do you think it is wise to use a cobbleter there? Sorry, sir.
Is fraught with years.
Voice.
Back with the endoscopic picture in a minute, boss.
Okay, sir.
मौके पे लीड कर नीचे चला नीचे अबे अनुपम उस फोर्थ को इंड्यूस कर दे ड्रिल रख ली फिर देखते हैं चीटी दिखे तो मेरे को बताना आ जाए इधर हेलो
Yes,
Yes,
sir.
sir.
Yes, sir. We are getting the endoscopic picture, sir.
endoscopic picture now. See the
Yes.
state of the surgical cavity. It's good.
Yes, sir.
And see the blockage in the frontal recess region, which he is suffering from. See this?
Yes, sir. Yes, sir.
Complete no access to the frontal sinus at all.
Yes, sir.
See this. How important is to ensure during primary surgery to give wide access to this area. See this?
Yes, sir.
Looks like this is the turbinate which is adhered. See this?
Yes, sir.
Do not know what happened. Let us see. And see about this is the region of the frontal.
Yes, sir.
So whatsoever the reason is, we will go head on and solve this issue forever.
Sir, what was the presentation of the patient to you, sir?
Headache. Massive headache.
Headache. Okay, sir.
Otherwise, a decent sinus surgery has been done. See this?
Yes, sir.
See, I'm just decongesting the area. See this?
Yes, sir. Yes.
We have no landmarks at all.
Yes, sir.
So frontal sinus work, if you do adequately, otherwise it gives more problem to the patient. Initial sinus disease patient is asymptomatic, painless.
Yes,
And
sir.
now after surgery has become symptomatic. See this?
Yes, sir.
We are working in the upper part of the nose.
Yes, sir. Middle turbinate has been removed, sir.
Yes, you
Yes.
can see it is chopped off.
Yes.
And we have no landmarks. So first,
True.
we have to discover the landmarks.
Yes, sir.
See, this is my cobbleter.
Yes, sir.
So I will uncover the bone first.
Yes, sir.
अरे यार इसको तो करो ना यार पानी आ रहा है? बढ़ा दे थोड़ा See, I am uncovering this bone anteriorly.
Yes, sir.
This here, the coagulator role is very important, so bloodless.
Yes.
Otherwise, this mucosa
Yes, sir.
is so richly vascularized.
True. Sir, is there a role of navigation tool too in
Yes,
this case?
can be useful if they are not well versed with anatomy. Yes, can be useful. See now,
Yes.
I'm elevating from the floor this mucoperiosteum till posteriorly to define my posterior limit.
Hello.
Yeah.
Satish sir, Dr. Anil Gwaliekar.
Yes. Hello.
Sir, good evening. Good afternoon.
Good
Sir,
afternoon.
I want to ask what should be the posterior most limit for this elevation of the flap?
See this, that's what I'm showing you. Can you see something?
Yeah. First fibers of.
See, the most
Hello.
anterior one is a branch of anterothymoidal artery. Remove it.
Yeah.
See this? See this?
Yeah.
Yes, sir.
Laterally. And below that, that opening belongs to first olfactory neuron.
Olfactory neurons, yes.
That's it. That is my limit.
Sir, anteriorly, from where we should start?
Pardon?
Anteriorly, from where we should start?
Anteriorly.
Anterior limit.
Yeah.
Anterior limit is skin. We have to discover.
Okay.
Anteriorly is no worries. That is skin. See now what has been done previously.
Yeah.
Yes, sir.
Now, I will remove this flap. I have seen my concern is this posterior limit. See this? Not the anterior one. This posterior limit is the concern. I should not go posterior to that anyway. If I try to go, will be CSF leak.
Yes, sir.
See all this scarring. See what I'm removing? Sorry. Under kar diya na next.
Fibrous tissues.
Saman logo. All fibrosis.
Yeah.
Tu kar dena. And frontal sinus drainage is completely blocked. See that?
Yes, sir.
All fibrosis, osteitis. Jana, tu kar. See how we are discovering the anatomy.
Yes, sir.
With the thick fibrotic band. I have to use this through cut. See below, I told you a decent work has been done below.
Yes, sir.
Reverse this. All this is fibrosis. Our frontal is here.
Yes, sir.
Reverse. Here is your olfactory neuron. See that here.
Yes, sir.
There is neuron. Okay?
Yes, sir.
Stop later further. I am just besides the posterior limit, all
sir.
limits all around is skin and skin.
True, sir.
So If I work anterior to this olfactory neuron,
Yes, sir.
here, there is no critical structure. So
Yes,
you
sir.
work in the safest zone. The
Yes,
skull
sir.
base is behind, you are working far anteriorly.
Yes, sir.
See, I have exposed the bone completely to drill off.
Yes, sir.
So my target area of interest is far anterior.
True, sir.
Now I am using my high speed bar. उधर पानी के लिए एक जना
Yes, sir.
खड़ा कर दो उसको पूरा कर दो. See, this is coarse diamond bar from Medtronic. Right
Yes.
now, it can go up to 75,000. I am using 60,000.
Okay.
See my outside periosteum?
Yes, sir.
Give me cobbletter to show you change of color. This is outside skin.
Yes, sir. That's the outer limit.
Yes. See this?
Yes, sir.
Outside, huh? So
Yes,
this
sir.
is your lateral limit.
Yes, sir.
Following the lateral limit, I am going anteriorly now. I know my outside skin now.
Yes, sir.
Parallel to that, following. Now this is all frontal sinus floor.
Yes, sir.
See, my first olfactory neuron is far behind.
Yeah.
And I am working far anteriorly in this direction.
Yes, sir.
There is nothing critical in this area. Okay?
Yes, sir. So your assistant is irrigating or it's a drill with the irrigating system?
Drill has a irrigation, but my assistant is also irrigating my
Okay.
field as well as telescope. See this bone.
Yes. Yes, sir.
See the high speed bar cutting like a butter.
Yes, sir. So, but when we don't have this drill system, can we use the normal routine marathon drill?
You can, but it will become very, very cumbersome.
True.
So this burr is having that soft cover also, no? So
Yeah.
that it is not coming in contact with the normal mucosa.
It is not coming in our way. This shaft has a, hold on, 15-degree angulation. See this
Okay.
Okay.
shaft. This shaft has an angulation, 15 degree.
Yes. Yeah.
So shaft is not coming in our way. See the beauty. And I am using only 0 degree.
Yes, sir.
Entire surgery will be done only and only by 0 degree. Later. See this outside skin.
Yes, sir.
This is outside skin.
Yes.
If I palpate from outside, you can see.
Yes.
You have to go parallel to it. This is our frontal sinus.
Yeah. But it seems our previous surgeon has also tried the frontal walk.
Yeah, that is what you can see here.
Yes, sir.
I am more and more widening the frontal sinus.
True, sir. It's cutting like a butter, sir.
Yeah, exactly. That's the beauty of this drill. See this thick mucosa.
Yes.
See this?
Yes, sir.
That is the frontal sinus.
Frontal sinus. Yes, sir. Sir,
Thick,
here would you recommend?
thick hyperplastic mucosa with no aeration.
Yes, sir. Here, would you recommend the removal of the mucosa, sir, because of
No.
that sick?
No. Ventilation, drainage.
Okay, sir.
See how the bad situation of the frontal sinus.
Yes,
See,
sir.
and see this bone. This is all osteitis.
True, sir.
See this bad bone.
Bad bone.
State of the frontal sinus is very bad.
Yes, sir.
See the frontal.
True.
पानी यार बोल लगे खड़ा कर देना 25 जने See, I am going far anteriorly.
Yes, sir.
Give me cobblator. For tissue bleeding, use cobblator.
Yes, sir.
See how much thick bone is there.
Yes, sir.
And my anterior limit is going to be the anterior skin.
Yes, sir.
We'll show you.
So you didn't take the mucosa for biopsy in this case because it is
Yes,
some
yes,
kind
yes,
of funny
yes.
mucosal disease.
Yeah. Definitely hyperplastic mucosa.
Or you didn't take it for biopsy, sir?
We'll take
Okay.
from the depth. See this outside skin, it's turning
Yes, sir.
anteriorly now.
Yes, sir.
See this becoming anterior skin now.
Yes, sir.
This is going to be the anterior limit.
Okay.
If you go further, you'll give buttonholing.
Yes, sir.
See, our limits are very well defined skin everywhere.
Yes, sir.
Skin on this side. Any bone has to go.
Yes.
So once you are doing draft, widen to the maximum.
Okay, sir.
Wash. Not possible the biopsy. But skin bleeding, coblata.
Yes, sir.
Sir, you're operating by three-hand technique. So that assistant stands in front of you, sir, holding the suction
Besides me.
besides you, sir. Because you are changing the instrument so quickly, like a magician, to the drill, to the cobbletter, to the microdebrider.
Sir, here's this thick mucosa.
Yes, sir.
This is for biopsy. No, बड़ी थे ना लंबी. Thick hyperplastic mucosa. वही थे, लंबी थी ना. Fundal. Yes. Some more for biopsy. Debrider. 40. See, everything being done with a 0 degree. What
Yes,
a
sir.
bad mucosa. You can imagine. And such mucosa in the closed sinus is extremely painful a situation. Here's the osteitis.
Yes, sir.
You can imagine how persistent this disease would have been.
Yes, sir.
Looking at the kind of osteitis. Now, wash and give me I will show you a picture with a 70 degree.
Yes, sir.
See the sinus.
Yes, sir.
$70. What a case.
Yes, sir.
This is your frontal sinus.
Yes.
Yes, sir.
With this bad hyperplastic and osteitis bone. Give me 60.
Yes.
See, this is your anterior limit. Skin.
Yes, sir.
This is your lateral limit.
Yeah.
You cannot go anymore. All bone or the frontal sinus has been removed.
Yes, sir.
That's the lateral part.
Yes, sir.
Good, healthy. See, this osteitis is what? Depot of infection in the bone.
Yes, sir.
That is the frontal sinus of this patient. Use. This was the source of problem. Lack of ventilation, lack of drainage.
Yes, sir.
Yes. Now our spheroid will reach.
Yes, sir. Definitely.
Yeah, that's it. Wonderful. Very good. So hope you understood the draft is drilling in the safe zone.
Yes, sir.
See the frontal sinus. This is, you can see in your OPD with 0 degree.
Yes,
And
sir.
our olfactory neuron is here behind, far behind.
Yes, sir.
We are couple of centimeters anterior to it.
Yes, sir.
This is the level of the first olfactory neuron here.
Yes,
And
sir.
we are working there. You can see that is the first olfactory neuron here.
Yes, sir.
This one. See that?
Yes, sir.
And we
That
are
was the
working.
only landmark, sir. Which is.
Yeah, that was the only landmark. The limit. This is your outer skin anteriorly.
Yes, sir.
This
Yes,
is your
sir.
lateral skin. So you cannot go beyond that anywhere. Thick
Yes, sir.
hypoplastic mucosa I have partly removed, and
Yeah.
access to the topical treatment is now fully opened
sir.
up. Reverse.
So you would recommend only nasal cleaning and nasal douches in the post-op settings.
Yes, douches. That's it. All this, everything, mucosa, everything will revert.
Anything to prevent osteitis further or the cicatrization further, sir?
That has become past. Now with the steroid therapy on, that doesn't happen. That used to happen in the pre-steroid era when steroid irrigation was not done. The
Yes, sir.
Lothrop procedure was fraught with the complication of stenosis because
Okay,
of osteitis. Now with the steroid, no osteitis happens.
Okay, sir. As it is a CRS, sir, so would you recommend anything for immune modulation
Yes.
in the post-op setting?
This patient requires a thorough immune assessment. See, there are a group of patients I mentioned about the immunity,
Yes,
which
sir.
requires a thorough immune patient. I mentioned which patient require desensitization, those have asthma.
Yes, sir.
Which patient require immune assessment, which have repeated calcitrant problem, recalcitrant disease,
Yes, sir.
severe repeated bacterial infections,
Yes,
severe
sir.
repeated multi-organ disease like
Yeah.
patient with this disease presenting with repeated otitis media, bacterial,
Yes.
repeated URI, LRI.
Okay.
So there is something in the immunity
Yes.
which is reflecting and responsible for this. Such patients require immune assessment. Every patient doesn't need. Patient
Yes.
requiring repeated treatment, antibiotics for the bacterial infection require immune assessment.
True.
So this is about the frontal sinus. See this?
Yes.
And I hope this patient to recover and enjoy the life as before. The last case I had shown you the CT scan.
Yes, sir.
Yes, sir.
You remember?
So
कौन सा
for
उसका
3
number था?
cases, a big
कौन सा?
round of applause for you, sir.
Thank you so much for your attention.
Wonderful surgery, sir.
Although it's a
Wonderful.
lunchtime, but the house is full, sir.
Oh,
क्वेरी में congenital cholecystitis
Everyone is enjoying surgery more than the lunch, sir.
वही query
True,
था
sir.
वो सारा
thank you so much, and
Thank you, sir.
I am grateful to you for your kind attention.
It's always our pleasure,
नहीं
sir.
खोलना, उधर से
The
लिख लो.
last case that you are about to demonstrate, sir, that reminds me of a case that you operated during COVID time, sir. It was having an
Yes.
extension beyond orbit, almost making an inverted J. And you demonstrated very nicely, sir.
Oh,
We
you
saw
remember?
that case with our neurosurgeon, sir.
Oh, really? You remember so much.
Thank you, sir.
So,
Thank you, sir.
this case, let me quickly, in a 1 minute, because the case is ready, induced,
Yes, sir.
the kind of disease this patient has. Allergic fungal rhinosinusitis. सुनो, जल्दी 1 मिनट में सामान. See this. This is a fungal disease. See the heterogeneity.
Yes, sir.
Yes, sir.
And this bone is there in between, narrowing the axis, outflow drainage. And
Yes.
because of that, because of the expansion in this area,
Yeah.
it has broken the roof of the orbit and it is prolapsing into the orbit.
Yes, sir.
Though the periorbita intact. This is not invasive disease.
Yes.
Now, which site is this? This is supraorbital recess. See this.
True,
Yes.
sir.
Look at the supraorbital recess opposite side.
Yes,
See
sir.
this? Supraorbital. Now, where is the frontal sinus? Let me go anteriorly.
Yes.
This is frontal sinus.
Yes, sir.
Yes, sir.
As long as bone is intact, floor is intact. See this?
Yes, sir.
As long as beak is there, this is sinus.
Yes.
Now, see, we are going behind.
Yes, sir.
Now the beak has gone. Now what this is? Supraorbital cell.
Supraorbital.
Cell. Yes.
And this because of the fungal disease, expansion into the supraorbital. See how it is expanded as compared to the opposite side.
Yes, sir.
So frontal sinus is anteriorly, supraorbital is behind, and now it is prolapsing into the orbit because this ventilation drainage is blocked.
Yes.
Yes, sir.
See this? Now I have to give a final answer to it. So we'll do a draft to quickly this side and remove this medial wall and roof of the orbit, bones. Keeping the periorbita intact, we push the periorbita opposite side and we'll have a huge drainage pathway, which can never
Yes,
block.
sir.
So that is the orbital transposition, very, very important procedure for such regions. Now, let me show you. This is your frontal sinus. See in the sagittal plane where the frontal sinus is. Can you see?
Yes, sir. Yes.
Now I am going behind. See this?
Yes, sir.
Now see here.
Shivam.
See here anteriorly was the frontal sinus. See there?
Yes, sir.
And this behind is the supraorbital recess. Supraorbital means this is orbit below.
See, almost posterior to the orbital, that ball.
This is above the orbit.
Yes, sir.
See here, this is above the orbit. This is
Yes,
above
sir.
the orbit, but behind the frontal sinus.
Yes, sir.
So frontal sinus was left anteriorly there. And this is behind the frontal sinus. See the cribriform
sir.
plate in picture. Cribriform plate in picture.
Yes, sir.
So this is not frontal sinus. This is supraorbital recess.
Yes, sir.
Got my point? See the maxillary sinus in view. This cannot be frontal. This is behind the frontal. And to confirm this, look at the sagittal section. Frontal is
Yes.
left anteriorly and this supraorbital is behind. Got my point? So,
Yes, sir.
here the minimal disease on the opposite side will not demonstrate you because of the time constraint. We will show on this side, here the pen sinusitis. Yeah. So, I will not show the frontal, the too much of the maxillary and the sphenoid sinus work. We'll just focus in the given time frame, because in the conference we have to wind up on time as well. We'll focus only on the draft and this orbital transposition, and that's it. Okay?
Yes, yes, yes.
So in a minute or two, we'll be back with the endoscopic picture.
Yes,
Yes, sir.
Any suggestion, questions, anything? Meantime,
Hello, how do you handle the orbital part with the disease which has gone into the orbit?
so disease is pushing the periorbita.
Not pushing, sometimes it invades also from this supraorbital lateral end.
Yeah, so invasive disease is a different disease. We need to know what kind of disease is that, is a fungus or something else. Invasive fungus is a medical disease, I told you. Invasive fungus is not surgical entity. Got my point?
Yes, sir.
So it depends upon what disease you are dealing with. It purely depends upon that.
Sir, aspergillosis post-op the specimen came out. So,
Aspergillosis is pure medical disease. Voriconazole.
okay.
Voriconazole is deadly to aspergillus. If there is aspergillosis, give voriconazole. That's it. You don't need to give anything else.
Yes, sir.
So
Voriconazole is hepatotoxic in few percentage of patients. And whenever we give voriconazole, we monitor liver function every 10th or 15th day.
Yes.
If it starts giving hepatotoxicity, we have to stop it. We have seen in one of the patient hepatic failure with voriconazole.
Yes, sir.
So voriconazole is a wonder drug. For invasive aspergillosis, is the drug of choice.
Yes, sir.
Whatsoever the size of the fungal lesion, doesn't matter. You don't need to operate or remove. Voriconazole will kill that.
Yes, sir.
The issue is patient should tolerate, should not be hepatotoxic to that. If it is hepatotoxic, then you have to move on to the other safer drug, though may not be or not as potent as voriconazole, but then the second line drug is isovuconazole, which is safe for both renal and hepatic point of view, but it is not as potent as voriconazole. So the drug therapy is also very important. And
Yes,
these
sir.
invasive patients, poor patient, most of the time, the problem is the late diagnosis. So
Yes.
the onus is on we surgeons to be suspicious about invasive fungal disease in the early course.
Yes, sir.
Many of these patients move from here and there, and their diagnosis is still uncertain. So we have to be very, very, suspicious about invasive fungal disease, because these
True.
patients are curable. Otherwise, it can spread to brain. It
Dr.
can
Jain,
spread
please
anywhere.
continue. We'll disturb you a little. There is a
Huh?
time for changing the guards.
Yes, sir.
So
Hello?
you please continue, Dr. Jain.
Yes, yes.
We are
So
listening to you.
we are changing to the endoscopic picture.
Yes,
Yes,
sir.
yes.
Yes,
And
sir.
will show only frontal part in this patient, nothing else.
Yes, sir. So this is Dr. Yashveer.
Yes, sir.
Sir, thank you so much for whatever you have shown.
All
Sir,
thanks to
2:30
you.
will-
All thanks to you. It is your show,
Yes,
and
sir.
I'm
Yes,
happy
sir.
to be part of it.
Yes,
Thank
sir.
you so much.
Yes, sir. Thank you, sir. Sir, 2:30 will be starting the next session.
Yes, yes. You can shut off any time. No
Yes,
problem.
sir.
I'll
Yes,
try
sir. Yes, sir.
to finish this frontal part as early as possible.
Sure, sir. Sure, sir. Sure, sir. Thank you, sir. So meanwhile, we'll change the chairpersons.
Convert karo.
Felicitate
Bill potato.
chairpersons. I request Dr. PC Sharaf, sir, to felicitate the chairpersons.
And thank you, sir, for wonderful demonstration, sir. Thank you, sir.
तो नीचे करना टेबल.
I now request Dr. Anil Gwalekar, sir, to please chair our next session. Thank you, Dr. Saurabh Pachauri and Dr. Anil Kumar Jain for chairing this session. Now I request Dr. Anil Gwalekar, sir, to please come and chair our next surgical session. And Dr. Ravi Kamble, sir. So please. Dr. Ravi Kamble, sir, requesting you to please chair the next session.
Amit?
Can we please switch to the endoscopic picture?
Satish sir, we are back with you.
Okay, sir. So, because of the time constraint, I am running little faster.
Yes, sir. So this is also a good experience to see how to do a fast surgery as well.
Fast endoscopic sinus surgery.
Yes, sir. Yes, sir. Even in our medical colleges, sir, at times it happens. The anesthetists say that, the last case मैं induce नहीं करूँगा. So then all the fast skills, we have to take it out of our bag to complete the case.
Anesthetists always love fast surgeons.
Not always, sir.
They hate surgeons who go slow. Whatsoever they do is different. They love always surgeons who are faster.
Yes, sir.
Anesthetics means time is important.
Yes, sir. Yes.
Cobbletter. Anesthetists are the backbone.
So what kind of instruction you give your anesthetist when you start the case of FES? What settings you want, or you do give or you don't do give anything?
Can you repeat, please?
What instructions you give your anesthetist before you start FES?
My anesthetist is very clear about it. I want a good surgical field. I ask him and he gives me a good heart rate below 60.
Yes, sir.
In sinus surgery, that's it.
Yes, sir. Yes, sir.
See here, in this particular patient, I told you because of the time, I am not going to go in the details of the maxillary sinus and all that. We have already discussed. So I am going directly toward the frontal. See the fungal disease. See, I will show you the landmarks. I have my landmarks in my mind. Will show you quickly. First, I will show you the middle turbinate, the lamina papyracea, the maxillaries here below, which we'll do later. After this demonstration is over.
Sir, can you please clear the landmarks again for us? Because it is difficult to make out what you are entering into.
See this. On the left side, this I have opened the axilla. This is the frontal process of maxilla laterally, and this is your middle turbinate. See this?
Yes.
This is your middle turbinate. Could you see the middle turbinate?
Yes, sir.
This is the middle turbinate. This is axilla. This is the lateral wall. I am not working at the maxillary sinus here.
Okay, sir.
And in between these three, I have discovered the lamina papyracea here laterally. See this lamina?
Yeah.
So this is my landmark, lamina. Now my area of interest for the draft is, this is all ethmoidal cavity, lot of fungal. I am not looking at it. See, to orient you, this is your axilla. Can you see very clear?
Yes, sir.
This is your middle turbinate, floppy middle turbinate. This is your frontal nasal process, and this is forming here the beak. Okay? This is forming the beak here.
Yeah.
Now this is your lamina papricia here. Okay?
Yes, sir.
I am not doing anything more than this inside and will directly go to the draft to show you the steps. All this fungal disease in the ethmoidal cavity, I am just grossly removing. See, a lot of fungus in the ethmoidal cavity.
Sir, is this a revision case or a primary one?
Primary.
Okay.
See this. Our maxillary sinus is here below, here,
Yeah.
which I have not opened. Hope you are oriented now.
Yeah.
Now our area of interest is this beak. This beak here. Okay?
Yes, sir.
Go the back. So we have to drill this beak. So first I will uncover the bone. Let me pack the cavity for a while to reduce this oozing. Now see, this area of interest is above. Like the last case you saw. See this?
Yeah. Sir, in such cases, do you like to prepare the patient for a few days before taking him to surgery?
Yes. Always. I mentioned in the beginning, preparation is the key.
But as we saw in the CT scan, there was rarefication of bone and dehiscence. In these cases also, you like to prepare the patient or just take into OT?
No, preparation is must.
Okay.
Preparation is for surgical, improving the surgical field. Preparation is not done from disease point of view. Preparation is done from surgical field point of view.
Okay, sir.
Now, this is our area of interest for the draft. See this?
Yeah, sir.
This is your frontonasal process forming the beak. So now what I am doing, I am uncovering this whole bone. Cobblator is the key. This patient has a massive disease in the supraorbital recess in the frontal, which has gone laterally. See, quickly I am using the ablation mode to remove this mucosa. I hope it is clear that I am uncovering this bone.
Yeah, absolutely, sir.
I am little on the faster mode. Our olfactory neuron is far behind there. See that?
Yeah.
Yes.
That is the area of the olfactory neuron behind. We are not going to go there. Our goal is to drill away this bone quickly. Next 10 minutes, this, and then 5 minutes for transposition, orbit. Drill. Now, we have to define our anterior and lateral limits. So first lateral limit, see this was the level of the axilla. My lateral limit, I will define staying just below the axilla. See this?
Yeah.
and first defining the lateral limit, and that will be defined by change of color. See, I'm going more and more laterally. Can you see the change of color?
Yeah, yes, I'm seeing.
That is the periosteum. Outside periosteum. See if I see this.
Yeah.
So that is my lateral limit. Quickly. Now, following the lateral limit, I will go anteriorly. If I violate the lateral limit, I'll give buttonholing. That's my point?
Yes, sir.
Please ask me again if there is any doubt on anything. Feel free.
Satish sir,
Yes, boss.
you are using your favorite instrument stylus. Tell something about it.
Stylus is amazing tool. Stylus gives you opportunity to drill faster, safer, with complete visualization.
So it's angled again microdebrader stylus
Yeah.
drill, by which you see the Satish is removing this bone like a butter, and very
Yes.
precise dissection he is doing.
And it is coarse diamond, so very safe.
Yes, not cutting accidentally anything.
अरे एकदम पानी की वीरू कर क्या रहा है?
So this drill has some particular angle.
15 degree.
Okay.
Cost is the only limiting factor. This costs around 40,000-50,000.
Per burr.
And disposable. See how it is cutting like butter.
Yes.
So we have not opened the frontal sinus from below. We are going head on for the frontal sinus, huh?
Right. We'll remove the base of the frontal sinus, that is beak, which we are discussing.
Even bone also looks to be osteoitic.
See, I am following the lateral skin up.
Yes.
Yeah.
So the first point is to define the lateral skin and then keep going up. See this?
Yes.
And anteriorly is ultra safe zone, nothing else than skin anteriorly. I told in the beginning, this is the safest zone for the endoscopic surgeon. See how thick the beak is. The thickness of the beak is sometimes 2 centimeter even. 1 to 2 centimeter is the usual thickness. So you have to drill this hardest bone in this region.
Yeah.
Once drilled, will be entering
Directly.
head on into the frontal sinus
Yes.
with 0 degree. I told you all the modifications of draft. According to the indication, you have to choose. Now see how much I have drilled the bladder.
We are just, I think we have seen the mucosa of the frontal,
Yes.
which you have pressed with the suction.
Yeah, that is what.
I think you can make a record on Guni's book of
Yeah.
world record, how to.
That is frontal sinus about. See that?
Yes, yes, yes.
So that is the initial entry into the frontal. And this patient, see the disease.
Yes,
I told
yes,
you this
we
is
are
behind the
seeing it.
frontal sinus.
Yes.
This is in the supraorbital region.
Supraorbital.
Yes, yes.
This is behind the frontal sinus. No? Let me show you. Huge disease just behind the frontal sinus. Cross section there. The frontal is anteriorly and disease is behind. And this lamina and the roof of the orbit is the obstacle which we are going to remove. See this disease. Huge fungus.
Huge, yes.
You're still working with 0 degree, sir?
Yeah, yeah. I never changed to any other telescope, only 0.
Even in lateral limits, 0 degree works properly?
See, once you remove the bone, it expands your visualization. I will show you the 70 also.
Okay, sir.
See this fungus.
Yeah.
This is high power section.
Yeah. Organ.
This is from supraorbital recess. Frontal is anteriorly. That's why I've been emphasizing on this anatomy again and again. See, frontal is anteriorly there.
Yeah.
A supraorbital recess is behind there. Wash.
Recess is almost clear, I think.
Or later. See, this is periorbita.
Yeah.
We have to elevate the periorbita to remove the bone. So what I'll do first, I'll stiffen this periorbita with the cobblator. Periosteum. See this bone, underlying bone. The bone I have to uncover and remove. See that bone?
Yeah.
Drill. More bone drilling. The beauty of this burr is this is not cutting burr. So this is very safe. Put on. And we are working in a very, very safe zone. No critical structure. All bones except skin, all bone is to go. I'm doing quickly now. Let me show you to orient with a 70 degree. Okay?
Yes.
High up where I've reached and what openings I have made. See with a 70 degree. Suction.
This is 70-degree view, sir.
Yeah, now 70 degree.
Okay.
Now see, this was the supraorbital recess
Yeah.
where I remove the fungus from. See the supraorbital recess.
Totally empty.
Yeah. And here anteriorly the frontal sinus.
Yeah.
Okay. And this is the party wall between the frontal and supraorbital. Give me. So I will remove the party wall and make a common cavity. See this?
Yeah, sir.
Point. See, this is frontal anteriorly.
Yes, sir.
This is frontal anteriorly. See the wide frontal sinus superiorly, anteriorly, sorry. See the scallopings inside this frontal.
Yeah.
This is supraorbital and this is the party wall. I am making both a common cavity by removing this party wall. See now?
Yes, sir.
So remember, supraorbital is a structure behind the frontal sinus. Also. Here I have made both a common cavity. I'm going far and far laterally. Again, to orient you, this above is the frontal sinus. See there? And this is your supraorbital cell. I have removed. Now, in order to go far laterally here, see now, this bone is the obstacle.
Yes.
I cannot go far laterally, so I need to do something to this bone. See this?
Yes.
Yes, sir.
That is the medial wall of the orbit. See this bone?
Yeah.
This bone.
Yeah.
So I'm elevating the periorbita. See this?
Yes, sir.
See this? Elevating everything
Yes.
from this bone. And remove this bone to make this opening wider. Flexion karna. See this bone?
Yes, sir.
Or the medial wall and superior wall.
Yeah. It's a crest forming the floor of that.
You see,
frontal-
I removed this bone.
Yeah.
Yeah.
I'll make bigger and bigger opening. Section. See the sinus opening becoming more and more bigger. See now?
Yes, sir.
This orbit was coming in the way, which I am removing. See the cavity there.
Yes, sir.
This periorbita, I will push again by means of stiffening it with the tablator. See this?
Yeah.
Whatever periorbita I have elevated, I am pushing it far and far laterally. See this?
Yes, sir.
Keep removing. Keep as long as you want. As far as you want to go. I'm stiffening the periorbita. So as long as you remain outside the periorbita, no damage one can give to the eye. Got my point?
Yes, sir.
Now see the area that this disease was going into the eye is exposed. And I will remove this bone. Yes. All this. So I'm working above the eye
Yes, sir.
using 70-degree, using 60-degree debrider, everything in angle. Frontal sinus is up there and I'm working over the eye there. See the difference in angulation.
Yes, sir.
See, I'm above the eyeball.
Yes, sir.
Later. Later. I'm working towards the periorbita. Wash. Yes. Wash. See this how the disease which was going into the eye from above, one can change out. You are not damaging anything inside the eye as long as you stay on the periorbita. See, I have pushed the eye and widened this axis. Yes, this one, cover the sections. See, we have removed the medial wall of the orbit. See this.
Yes, sir.
Again. One. Very well. See, orient yourself. This is your frontal sinus.
Yes, sir.
This is your supraorbital recess.
Yeah.
Now, there was a bone which was separating the orbit from the supraorbital, and this is supraorbital bone. See this?
Yes, yes, sir.
We have removed and we have got this access towards the orbital roof. Can you see?
Yeah.
Very
Completely
clearly.
access the, see this?
Supraorbital cell here.
Yeah, yeah.
Supraorbital. This is orbital periosteum.
Yes.
Yes.
This is doesn't go beyond the periosteum, but we have given full access.
Yeah.
This is called orbital transposition, by means of which you can access, widen, and give a permanent drainage. What's my point?
Yes.
Yeah,
sir.
yes.
We have given a permanent drainage to the
Supraorbital
supraorbital
cell.
area. Yeah, see this? This more bone. Stay on the periorbital. That is the key. Okay. So, in a minute's time, you can switch over. My goal was to show you this important procedure. By means of transposing this orbital wall, we have a wide access. See, laterally, we have a wide access.
Yes, sir. Beautifully exposed.
It is not about the disease removal, it is about the permanent drainage. For the future, this, the process is given. Funny, though. See, this way you can go far laterally wherever you want. This is a wonderful procedure, and that's the only procedure which can establish a drainage for future. It's not about disease removal. Here is supraorbital cell.
Dr. Jain, is there
Yeah.
any chance of displacement of the eyeball?
No,
because
no.
of removal?
See this. As long as your periorbita is intact, you never give any damage to the eyeball. Stay outside the periorbita. If anywhere you happen to damage the periorbita, keep coagulating the orbital fat, nothing will happen.
Right.
See this? That is where the disease has gone inside. See this orbital periosteum was destroyed.
Yeah, yeah.
Removed. That's it. I know I have crossed your time frame, so
No, but it always a pleasure to
apologize
watch
for
you,
that. I know conferences, time is important.
Dr. Satish. It's always the hall is enjoying your excellent surgery. It's like a poetry everybody has enjoyed. The way you reach to the difficult areas, the way you teach, it's really excellent. And we are proud to have you among us. And thank you very much for sparing the time.
Thank you so much, and thanks to everybody and the organizing team, Dr. Yashvi, Dr. Dubey, and everybody. And thank you all the participants for bearing me.
Thank you,
And
sir.
wish you all the best for the conference ahead. Thank you so
Yes,
much.
sir. Thank you so much, sir.
Thank you,
And
sir.
on behalf of organizing team, we are inviting you for tomorrow's gala dinner, sir. That's
Let's
my
hope.
duty to invite you, sir.
Thank you. Thank you for that.
Yes.
So,
Thank you, sir.
thank you, sir. Thank you. Hello?
Uh, I'll request Dr. Pipal to felicitate the chairpersons, Dr. Anil Gwaliarkar and Dr. Ravi Kamble.
Zero there. मामू को बुलाना. Disconnect. What is there?